Bore da, a chroeso cynnes iawn I bob un ohonoch chi i'r cyfarfod yma heddiw, sef cyfarfod bwrdd Iechyd Addysgu Powys. Ac fel y gwelwch chi, dyn ni yn prif ffrydio y cyfarfod heddiw, ac yn ôl ein harfer, mi fydd na recordiad o'r cyfarfod ar gael o'n gwefan ni yn dilyn y digwyddiad heddiw. Carl Cooper ydw I, cadeirydd y bwrdd, ac yn fuan iawn, fe welwch chi ar y sgrin manylion am ynghydweithwyr eraill, sef aelodau eraill o'r bwrdd. Aelodau annibynnol yn ogystal ag aelodau gweithredol. Hefyd, fe welwch chi wybodaeth am bobl eraill, mynychwyr ychwanegol, fydd yn cyfrannu at ein cyfarfod heddiw, ac hefyd bobl sydd yn methu bod gyda ni heddiw, ond dyn ni wedi derbyn eu hymddiheuriadau am absenoldeb. A very good morning and a very warm welcome to our meeting today, a meeting of the board of Powys Teaching Health Board. We are, as always, live streaming our meeting, and there will be a recording of the meeting available from our website after today's event. My name is Carl Cooper, I'm the chair of the board, and just in a second or two, you'll see on screen details of other board colleagues that will be in the meeting today or contributing, so independent members and executive members. Also, we have additional attendees today who will contribute to various agenda items, discussions and conversations. You'll also see there that some of our colleagues can't be with us today, and we have received their apologies for absence. And I'd like just at this stage as well, simply to note at this stage that today is the last meeting for Kirsty Williams, our Vice Chair, and she's due to leave us at the end of this month to take up a new role as Chair of Cardiff and Vale University Health Board. Also the last meeting for Claire Roche, who retires from her role and leaves us on the 10th of October. Claire, our Executive Director for Nursing, Midwifery, Children and Women's Services. I just want to note that for now. I will just perhaps say a word of thanks and appreciation towards the end of our meeting. But we are the board, we are the governing body of our organisation. Corff llywodraethol y sefydliad ydyn ni fel bwrdd, ac fel bwrdd mae gennym ni yn benna 4 cyfrifoldeb. Y cyfrifoldeb cyntaf, falle, ydy bod ni yma I osod cyfeiriad strategol ar gyfer y sefydliad. Yn ail, dyn ni yma I osod archwaith risg wrth I ni gyflawni yr amcanion strategol. Yn drydydd, dyn ni yma I fonitro cyflawniad a pherfformiad yn erbyn yr amcanion strategol hynny. Ac yn bedwerydd, ond nid yn lleia, achos mae'n holl bwysig, dyn ni yma I osod diwylliant y sefydliad yn seiliedig ar ein gwerthoedd ac ar ein hegwyddorion ni. So as a governing body, we have 4 main responsibilities, and those are to set the strategic direction for our organisation, to set and manage the risk appetite and the delivery of our strategic aims. We're here also to monitor performance against those strategic aims and against our plans. And fourthly, and certainly not least, because it is of supreme importance, we are here to model and to set the tone and culture of our organisations driven by our values and our principles. Dyn ni'n cyfarfod heddiw yn unol ag rheoliadau y gwasanaeth iechyd yng Nghymru. Hynny yw, dyn ni'n cyfarfod yn gyhoeddus, ond mae'n bwysig dwi'n meddwl jyst I amlinellu taw nid cyfarfod cyhoeddus ydy hwn. We are meeting today in line with our NHS Wales regulations. We are meeting in public, but it's important to make the distinction that this isn't a public meeting. So we don't invite direct participation from members of the public. However, we do welcome and we do invite questions and feedback from members of the public. And if anyone would like to know how to submit a question or how to submit feedback, then please look at our website because you will find more information about that there. And so also the agenda and papers for today's meeting are available on our website. And so anyone that would like to follow the detail of the information that we are here to consider and discuss today, all of that is available, and please do access it. People will see that later in our agenda, we have a so-called consent agenda, and that's in section 5 of our agenda. And just by way of brief explanation, the items under this agenda are important items, but routine items, items that are non-controversial and items that have been deemed don't need discussion. There will be an opportunity for any member to, if you like, raise any item from the consent agenda and place it as a substantive item for discussion on the main agenda, should anyone want to suggest that. However, when we come to the consent agenda, we will deal with those items without discussion and en bloc. And as we go through our meeting, we have a reasonably long meeting today. We will, of course, be taking breaks at certain point, and at around about 1 o'clock or thereafter, we will break for lunch as well. Felly, dyn ni symud rwan at yr agenda, ac dwi'n tynnu'ch sylw I gychwyn at item 1.2. We go to item 1.2 of our agenda, declarations of interest. In our papers, you will have had a copy of our register of members' interests. Can I ask, please, colleagues, does anybody want to declare an interest in relation to any item on our agenda today? I can't see that anyone does, and so there are no declarations of interest. In which case, we turn to 1.3 on our agenda and to the board action log. And I'll invite Helen, our Director of Corporate Governance and Board Secretary, just to draw our attention to the items on the action log, and particularly, of course, the ones that are still open. Thank you, Helen.
Diolch, Carl. Bore da, everybody. Helen Bushell, Director of Corporate Governance and Board Secretary. Members, there are just 2 items on the action log, as you'll see. I'll come to the second one first. It's on track in relation to our integrated quality and performance report. And in Nick's absence, when Chris Moss picks up this item later on the agenda, he will provide an update within that item about that particular action. And Carl, I would suggest we just loop back round that later and check we're content that that's been responded to. The at-risk item on the agenda is in relation to the People's Experience Framework. You'll recall, and you can see in the update, that this has been ongoing for a period of time, largely out of our control, while we've been waiting for some national guidance that has now been received on the framework. That will be presented to our Patient Experience and Quality Committee in November, and will therefore come to board in due course in November also. So it is on track insofar as we can control the timescale, but off track in terms of what we'd initially anticipated. So, Carl, we're asking for the board to agree a date change to November today for that item. Thank you.
Thank you, Helen. So just before that, can I just ask either Claire Roche or Kirsty Williams, Chair of our Patient Experience Quality Safety Committee, because this item is there because, if you like, we are looking to this framework to help us bring a more systematic approach to our patient voice capture and patient voice understanding. So admittedly, the timetable has slipped a little, but I just want some assurance that that is still the case, because so I can see Claire's hand up. Please come in.
Yeah, thank you, Chair, and thank you, Helen. So just to give you some assurance, Chair, the report that will come to the PACS committee in November will be quite a comprehensive report detailing how us as a health board will deploy the National People's Experience Framework within the health board and our mechanism for doing that. And given that during the summer we've appointed a People's Experience Coordinator, which is the first time we've had that role in the organisation, I can confirm that it will be a comprehensive report in PECS and board will receive it following that.
Thank you. So, colleagues, for the reasons given, we are asked to simply approve the change in the time frame, and this will come back to us in November rather than in October. So, it will be considered by PECS in October and then come back to us in November. Please indicate if you're Helen. I can see that you want to come in.
Sorry, Carl, just I have a separate point to raise as well. If you just want to conclude the action log, and then I'll raise a separate point if that's okay.
Absolutely fine. I don't think anyone wants to come in with a different. So we do agree that. So please come in, Helen.
Yeah, thank you, Carl. With apologies to you and board members, I think we've just got a technical problem with the live link. We're getting some messages that external colleagues to this meeting haven't been able to join. So, Carl, apologies. I'm wondering if we could just take a pause just while we try and work out what it is that's going on in the background. So we are not live at the minute. People can't access the live stream.
Absolutely fine, Helen. It's really important that that this meeting is held in public and that there is access. So, do you suggest that we stay in the meeting, or
suggest we just stay on the meeting? Liz, can you pop the slide up that says we'll resume shortly, and then we'll just connect in the background, Carl, with my colleagues, and I'll come back to you very shortly.
Okay, thank you.
Carl, with apologies, we just had a slight technical problem in the background. I can confirm that members of the public can access the live stream, and indeed our live attendance has just increased as well. So apologies for stopping the flow. We just got to the end of the action log, so I'll hand back over to you. Thank you.
No apology needed, Helen. Technical difficulties can and will happen, and thank you very much to you and colleagues for addressing that and for sorting it out so quickly and smoothly. I'm not going to go over the preliminaries to the meeting again. They will be available in the recorded version of the meeting that will be available online. We had just completed item 1.3 on the agenda and dealt with the actions on the board action log, and therefore we go to 1.4 on our agenda, the patient experience story, and I'll invite the Executive Director for Nursing and Midwifery, Claire Roche, to introduce the item, and also our Executive Director for Therapies, Claire Madsen, will also contribute to this item. Thank you. Claire Roche.
Carl, I think I can just pick this item straight up for you, if that's okay.
That's absolutely fine. Yeah, please do that.
Okay, so hello everyone, I'm Claire Madsen. I'm the Director of AHP's Health Sciences and Digital. I'm really delighted to introduce this patient video this morning. This story is about pulmonary rehab, and that is a structured programme of education and exercise for people with chronic lung conditions that our multidisciplinary respiratory team runs. It's a programme that supports people to improve the quality of their lives and live with their breathing problems. So we'd really like to thank our patient for taking the time to share their story of participating in this programme. So we'll go straight to a video that we have, and we'll let our patient explain what pulmonary rehab was to them and their experience of it. So thank you, Carl.
Well, all this started when I was having problems, tightness, breathing and getting colds. So I went to my GP and they put me onto all these different antibiotics. And then they suggested that I go for a test. And the results came back that I had pulmonary fibrosis on both lungs. And with the pulmonary fibrosis, I do find it occasionally get out of breath. I know my limits now. But being a bloke, we think we can go further than we actually can. After asking and going into what treatment was available, I was put forward for the pulmonary rehabilitation course. The pulmonary rehab that I went on in Newtown was excellent. Not only talking to the group, there's 10 of us on the course, but also people that were holding the course, Tony and Haley, plus some other physios and dietitians came in. But I found that it was very easy. You weren't pushed, you were helped, you were cared for. I didn't know I had this condition, but as soon as I did discover through my local GP, the health service, the health practice, were very quick to arrange different treatments for me, explained to me in layman's terms what I could and couldn't do. I play golf on a flat course, and what I do, if I'm playing 9 holes, I'll walk. If I'm playing 18, I'll go in a buggy. I know my own limits, and it's very important that the people or the person who's got the condition knows their own limits and not be persuaded by other people to try and push themselves, because that's not going to be beneficial at all. You know your own limits. go to the rehabilitation course, learn and listen to all the advice you're given with the different breathing exercises you do, the diet, all the aspects of it. The exercises I find have improved, they improve your posture straight away, because to do them properly, you've got to sit or stand properly. And you think to yourself, why am I doing exercises for my lungs? Well, I suggest you go along and listen to the physio and anyone else that comes along, and they will explain, not in medical terms, but in normal terms. We're not doctors, we're just normal people wanting to get the best out of life as you can, because I know this is going to get worse. I know that. But if I can stay away from medication as long as I can, and it's going to help me by doing the right things for me as an exercise, and I can put off medication, the longer, the better it will be for me. But it's very important to, if you need help, ask for help. The worst thing of all is to struggle, but you find out a lot of things. One thing that I'm a big believer in, and I'm a huge believer in this, if you ask somebody how they are, have the courtesy of listening to their answer. Don't just walk away, because if you do that, the worst thing you could do, it'd be better off if you didn't ask them at all. And then ask them how they're doing. They'll tell you. They feel better because somebody cares about them, and you feel better as well. And then it's just a case of getting on with your life. I've been told that if I need to speak to the pulmonary rehab nurse, I've got her phone number. Phone her any time I wish, which is, it's a safety net. Thank you very much. Over and out.
Thank you to our patient who shared this story. I just wanted to say that this was an audio recording that the patient gave us, and we've just used some stock images there to maintain the patient's anonymity, which they have preferred. So unfortunately, that wasn't a golf course in Powys, but thank you very much.
Oh, Claire, and thank you to you, but also a big thank you to the patient who agreed to share his story with us. As always, very thought-provoking, very affirming, and certainly it shows the value of the service, and of course the skills and the experience and the expertise of the staff who provide that service. So much appreciated. Colleagues, our practice is not to open a patient story for discussion per se, but actually it makes all the things that we're going to discuss in our meeting today real, and we certainly have that in our mind as we go through our meeting and discuss the performance reports and so on that we will consider today. But thank you very much to the patient. In which case we go to item 1.5. We have not received any questions from members of the public for this meeting, and so there is nothing to respond to, but it's probably just worth my mentioning that we recently held our annual general meeting, and we had a number of questions from members of the public in Powys at that meeting that we did respond to live in the meeting. And also there were one or two responses that may have been provided outside of the meeting. So a big thank you for those. And to reiterate what I said earlier, we always welcome feedback and questions, and the information about how to do that is available on our website. So that takes us to item 1.6 and to the update reports. Initially, my chair's update, which I will take as read. However, there is just one matter I need to draw to colleagues' attention, and that's the section on the Public Services Ombudsman for Wales annual letter. We did receive correspondence from the Ombudsman's office after we published this report and letter to say that they had identified some inaccuracies in the letter, and therefore they have withdrawn the letter. They will correct those inaccuracies and they will reissue the letter very soon. And so my suggestion is therefore that we consider that as withdrawn, and therefore we don't discuss that today. It will, of course, when we do receive it, receive the corrected version, it will receive detailed scrutiny through our Patient Experience Quality and Safety Committee, and then it will come to us as a board subsequent to that committee. But with that one additional comment, I have no other additional comments to make on my report, but I'm very happy to for people to ask questions or make comments. Does anybody want to contribute? No, so thank you. In which case, I'll invite Kirsty, our Vice Chair, to introduce her report and offer any additional comments, Kirsty, that you would like to.
Thank you very much, Chair. It is a short verbal report for me on this occasion. Since the last meeting of our board, the Power of Discharge Committee has met and continues to our hospital managers, which are, an incredible resource that the Health Board has, continues to carry out their functions in monitoring our compliance with mental health legislation. In terms of partnerships, over the summer, the Regional Partnership Board, and indeed the boards that sit beneath that, our Start Well Board, our Live Well Board, etc., have been undertaking a number of self-assessment and development sessions, which have been very well attended and incredibly positive, and look to shape the work of the RPB going forward. Carl, as you said at the top of the meeting, this is my last meeting as Vice Chair of Powys Teaching Health Board, and I just wanted to place on record my thanks to all colleagues on the board for their support, their colleagueship and friendship over the time that I've been in Powys. But if they won't mind, I'd like to say a special thanks to every single member of staff here at Powys Teaching Health Board. I have been amazed, not surprised, but continually amazed by the incredible dedication of each and every member of the staff, who are committed every single day to providing the very best service they can for the people of Powys. And I just wanted to formally record that today. Many thanks. Diolch yn fawr.
Oh, thank you, Kirsty. Much appreciated. Colleagues, does anybody want to ask a question in response to Kirsty's oral report, or make a comment? No, so thank you. And that takes us then to Hayley, our Chief Executive, and to her report. Again, we'll take the report as read, Hayley, but do you have any additional comments?
Bore da pawb. Yeah, no, I think from my perspective, Carl, the issues in the report are sort of covered. I think that wanted to particularly also thank Kirsty for her support as Vice Chair in the Health Board over the number of years we've worked together, and Kirsty will be sorely missed. I'm happy to open up to any questions. Thank you.
Thank you. So we go to Dr. Robert Lewis, independent member. Thank you, Robert.
Thank you for the report, Hayley. Two queries from me. First is the third sector commissioning review. Now, there might be some people, either service providers or recipients, who might be a little anxious about this review. Will you be involving providers in these discussions in any way? That's my first question. And then the second question is about the stroke services. And of course, we already have had some changes to stroke services for people in Powys already, but we've also now got the proposals from Hywel Dda. I think the point about stroke services not being part of an all Wales vision is well made, although the same observation might be made in other medical disciplines too. The absence of an all Wales plan may cause rural areas to lose out, and this is particularly important when so many health boards are reconfiguring to cope with service or financial pressures. So taking this wider issue, realising that what might be best for one health board might not be best for the patients in Powys, and anticipating even more dramatic and more rapid change next year. Have representations been made to government and the NHS executive about the need for an improved strategic coordination of services? Thank you.
Thank you, Robert. Hayley, just before you respond, I wonder if I might just piggyback, as it were, on Robert's question in terms of the third sector review. Robert asked about organisations being involved or providers being involved. I just wondered, from my perspective, in relation to our sightedness as a board. Now, Jen isn't with us today, who's our third sector independent member. Now, I'm not suggesting for a moment that we or she be involved in the operational detail or development there, but it's more of a kind of Jen's role and our board's sightedness on that as it is being worked up and as it is being developed. And linked with that, we have a couple of other papers on the meeting, on the agenda today. So in your report, for example, you mention a new framework for third sector commissioning. Of course, we will be discussing in a few minutes our new strategic commissioning framework. So I'm just asking, really, are they aligned? Are they linked? And also, we will be coming later in our meeting to the Director of Public Health's report on prevention and early help. And when you read that report, the role of the third sector is arguably writ large in the effective delivery of that report. So again, just seeking a bit of assurance that whatever comes out of the third sector commissioning work will actually support the delivery of the strategic frameworks and so on that we are here to discuss and potentially approve today.
Thank you, and really excellent questions. So if I start with the third sector review, just acknowledging, Robert, that whenever we undertake a review, that does cause some concern to both several organisations, but also to the recipients of the services that they provide. Just to give you some assurance, the framework, this is about how we undertake the review, and that has been set out clearly in terms of the approach that we will take, built really on the learning that we've undertaken in the space of partnership working through the Regional Partnership Board, and that obviously will involve conversations, discussions, and the full input of the affected organisations in the review. So I want to give you some assurance, Robert, this isn't a desktop undertaking. This is part and parcel of the process. There'll be discussions with each of the respective organisations. In terms of the role of the board, and particularly you referenced Jen's role as a third sector lead, we will obviously be doing this work during Q3, initially reporting back to the Executive Committee, and subject to the findings of the review, we will ensure that that reports through appropriately to the appropriate committee and, if required, to the board. So I just wanted to reassure you that is part of our thinking around this. Your general point, Carl, about how all of this fits together is a really important one. Clearly I've got to acknowledge, first of all, the complexity. We've got a number of frameworks, both locally as an organisation, regionally and nationally in the context of this work. And clearly we work in a policy context where priorities are set at an NHS Wales level through the annual planning guidance that we receive, and then we work through how we deliver through those priorities and policies at an organisational level, and that's part of our annual delivery planning process. I think prioritisation, particularly around how do we align the various frameworks and how this all fits together, is something we need to attend to really carefully, particularly how that maps against our local needs and how then that is reflected in our overall delivery plan as an organisation. And I think that the prioritisation conversation about how these align, obviously this is about making some choices. We are in an environment where resources are currently constrained, so we need to use our principles to guide our decisions, balancing current need, clinical need, financial sustainability, and also the ambition that we've set around improving population health, so focusing on well-being and early help and support. And then, so our annual delivery plan will bring all of those elements together. And clearly the other issue is around how we track against that. Clearly the performance against plan, our governance and reporting is set out, I think, quite clearly where we receive that, and once our priorities are agreed, and then we monitor that through the board reporting, and in particular, if we need to, there's a clear process around change control where if we need to adapt through the year due to other reasons, that we have that clear conversation and reporting back through to board. So I hope that gives a little bit of assurance around, how this work will be undertaken. And part of the reason we want this work undertaken in Q3 is, again, to have that early conversation with providers, recognising that we need to recognise sustainability, and there are some service sustainability issues that some of our providers are experiencing as well, particularly in the third sector. With regard to stroke services, I know that Kate Wright would like to come in, so I perhaps will ask Kate to come in first, and then I'll come in additionally, if that's okay. Thank you.
Good morning, everybody. Kate Wright, Medical Director. So thanks for the question, Robert. I think the join up of the conversation, discussion and planning around potential service changes is really, really important. So we know we have complexity in that services are delivered from lots of health boards around our borders, and we know that at the moment that there are potential service changes being discussed. So first of all, just to reassure that we are actively engaged in conversations directly with the health boards that are looking at service changes, to work through together what implications might be and make sure we safeguard the treatment of our residents. But from that conversation, as you said, it's really becoming very clear that there's a need for a very joined up plan. So another conversation that we have the Mid Wales Joint Committee, and as part of that, I chair the Mid Wales Clinical Advisory Group, and we have been commissioned to review and comment on the implications of potential service changes for the Mid Wales area. So that work is commissioned and will report shortly. I think that there is opportunity for shared learning there and service improvement, which is great. But I think it's very likely that one of the recommendations will be, as well as highlighting any risks and benefits from service change, will be that this also needs to be looked at not on just a regional level, but on a national level. So I think those recommendations are coming through and will continue to. So I think that is work in progress and something that will be promoted.
Thank you, Kate. And just to Robert, your specific question, in the All Wales context, I know that we regularly discuss the position around the various pieces of work that are being currently taken forward on either an organisational or a regional footprint, and the need to actually contain and review that at a national level. So there will be further discussions with the support of the network to look at some of those issues, particularly relating to stroke. I think the key issue for us in Powys is that's one way of looking at it, which is all Wales, but for us, the pathways cross-border into England is also a key consideration. So we'll need to ensure that that is covered fully when we understand the interdependencies between service changes that may be proposed around our borders and what that then looks like from a particularly for Powys and the rurality point that you raised. We'll need to understand what that picture looks like. But just, in terms of the Hywel Dda case, they've had a substantial response to the consultation and are currently reviewing that. And once we understand what the, feedback and options that the board will want to consider, we'll be able to take that more consolidated look across the rest of Wales. Is that okay, Robert?
Yes, thank you. Very thorough and reassuring replies.
Thank you, Robert. So we'll go to Mick.
Thanks, Chair. Mick Janassi, independent member. Hayley, really good to see that the Grant Thornton work is now starting to gather pace. I appreciate time is limited, so I'm not looking for a kind of detailed explanation, but just looking for some reassurance that there is a mechanism in place that will start to feed through actionable and measurable improvements in real time, rather than waiting in due course for a kind of set piece report.
Yeah, really important point, Mick. And I probably should have drawn the attention of the board in my introduction to the fact that through the escalation status that we are currently in for finance planning and strategy, Grant Thornton has been appointed to come in and offer external review and support to look at particularly our financial sustainability and plans, with a particular focus on commissioning and continuing healthcare. So there is a clear path of work that's been set between now and Christmas in terms of the overall work being undertaken. But just to give you some assurance, the field work, diagnostic work is currently being undertaken. And I understand Carl, as chair, met with Grant Thornton only earlier this week to discuss the work that's being undertaken. And just to reassure you, recognising the particular financial challenge, which we'll be covering later in the agenda around our in-year delivery of our financial plan, we have agreed with Grant Thornton that as they undertake their work, they will be telling us as they go along, rather than waiting for the set pieces of reports. And I think it'll be very important that when we receive those assessments and initial findings, that we discuss that as a unified board, recognising there may be further opportunities, hopefully, that they can identify to support us to take further action in year to improve our financial position. So yes, there are set pieces, but we have already agreed, and we meet on a weekly basis to receive an update on the work as it's progressing.
Thanks, Ellie. Thanks, Chair. That's reassuring. Thank you.
Thank you. So there are no other contributions in response to the Chief Executive's report. So a big thank you, Hayley, as always, and appreciate the report. In which case we go to item 1.7 on our agenda, and these are the reports from our committees. And as I always explain, I think it's really important to explain, the work of the board isn't restricted to these meetings. We do have a lot of activity that happens outside of the public board meetings, and very, very importantly, it's the work of our subcommittees, where the detailed scrutiny and consideration of matters take place. And so, and the chairs of those committees are key people for us as a board who, if you like, hold the reins or are the custodians or the conduits of that very crucial source of assurance for us. And so we're going to start with the Charitable Funds Committee, which I chair. I'll take the report as read. I don't have any additional comments to make to that report, but very happy for people to ask a question or to make a comment. No, so in which case we turn to our Finance and Performance Committee. Ronnie, the chair of this committee, has offered his apologies. We've accepted his apologies. He can't be with us today. And so, Helen, you're going to cover this in his stead.
Thank you, Carl. I'll do my best, but clearly not as good as Ronnie might do it. So the committee met on the 2nd of September. It had, as always, a significant agenda. There is a full report in your packs along the Alert, Advise and Inform report, as you're aware, for the board. At the top of the agenda was the organisational escalation status, and Hayley has already covered some detail on that in her report a little bit earlier. The committee always receives the most relevant and timely finance report. That was the month 4 one. Today, the board receives month 5. The committee also received the integrated quality and performance report at month 3. Today we have month 4. So there is always a timing difference, but just some reassurance that those earlier reports were considered in depth in the committee. There was then a significant series of assurance reports that feed into the wider work of the organisation and the performance reports that come to the board. And those reports included continuing healthcare, mental health provider provision, variable pay, general medical services and capital and estate monitoring. And assurance was sought against all of those reports. Carl, thank you.
Thank you, Helen. Colleagues, please do indicate if you would like to ask a question or enter into conversation in response to this report. I can't see anyone asking to do that, in which case we thank the committee for the report, and we turn now to our Planning, Partnership and Public Health Committee that Robert chairs. Over to you, Robert.
Thank you, Chair. Some of the matters discussed on the 14th of August form part of today's board agenda. This includes Better Together, the annual report of the Director of Public Health, elements of strategic and service change, and also rather soberly, winter planning, which has been brought forward across Wales this year. Elsewhere, we were updated on the responsibilities of the Health Board under the Additional Learning Act, with the need for compliance expected to increase, and accordingly a further update will be presented to the committee in 6 months' time. That's it from me, Chair. Thank you.
Thank you, Robert. Again, I'll pause. Should there be any contributions or questions from any board colleague? No. So we then turn to Kirsty and to the Patient Experience Quality and Safety Report. Over to you, Kirsty.
Thank you. I will take the report as read, but just to highlight 2 important issues. The committee was very pleased to note the decision by the Executive Committee to de-escalate children's neurodiversity services. Members will be aware that there had been some concerns around that service and had been placed into local escalation. But thanks to the extremely hard work of the staff, the Executive Committee felt it was now appropriate to de-escalate to a lower level that service. There have been significant improvements, not least the elimination of an internal waiting list and the ability to sustain a performance at 104 weeks. However, despite the lower levels of escalation, the committee will continue to monitor the performance of the service, recognising there is still substantial challenge those are still very long waits for families and for children. And at our next committee meeting, the committee will receive additional information around the financial sustainability of that service. Performance has been improved because we have been in receipt of additional resources, and also to have further information around qualitative data rather than just quantitative data. So we know that we're doing more assessments, and that's very welcome indeed, but we would like to understand, further details of the quality of those assessments. Of course, one of the things that will help us, and that has been a significant development in this service, is the creation of parent groups. So for the first time, we are directly hearing from the families of children who are using our services, and they have been fundamental in being able to provide feedback to the team around the quality of the service and helping us indeed design the service going forward, which has been a real step forward for us and has been very welcome. Moving then on to the issue of a patient experience, which was touched on earlier in the action log. The committee a while ago now raised the issue of Civica, which is just one system, just one way in which the Health Board collects data around patient experience. And we were concerned about our ability to fully exploit the capacity of that system. But as you heard from Claire earlier, for the first time, we now have dedicated resource to help us coordinate the very many ways in which the organisation collects patient experience and stories. And that person will be presenting, as Claire said, a very comprehensive report we expect at the next PECS committee that will help us to understand our performance against the national frameworks that have now been published to see where we are in that regard. But if there are any further questions, I'm very happy to answer them, Chair.
Thank you, Kirsty. It's really helpful and very affirming as well. As you say, more work to do, but some good progress been made, and thank you for that. So again, colleagues, please indicate if you'd like to make a contribution in response to the PECS report. No, everyone is satisfied, and therefore we turn again to Hayley, to our Chief Executive, and for the Executive Committee report. Any additional comments, Hayley?
Thank you. So you can see from the report that we have met 5 times since our last board meeting, and the practical matters that we discuss, as well as the work en route towards the committee. So I'm not going to cover items that colleagues have already covered in the committee reports, but I just wanted to draw attention particularly to the space of digital around some key developments that we have discussed and moving forward with in the Health Board. The first being the need to find a replacement to the Welsh Community Care Information System and the work required to take that work forward. That's been a key area of discussion for us as an executive committee, and in particular feeding into the national programme that's led by Digital Health and Care Wales. The second being regarding the really important work you've received assurance previously about the equipment replacement that we've put in place in terms of our radiology services. There has been a replacement piece of work coordinated on a national basis to replace the radiology information system, and also something that's called PACS, which is the way in which pictures are archived and communicated across the whole of Wales. That is continuing to move forward for us, and clearly is an important aspect of ensuring that we can get that sharing of information across health boards. And then the final is the work that's being undertaken nationally around the maturity of digital work across the whole of Wales. So we've undertaken a self-assessment and that has been forwarded as part of the national piece of work that's being taken forward. So those are the 3 key matters I particularly wanted to draw the attention of the board to. Thank you.
Thank you, Hayley. Colleagues, does anyone have a question or contribution in response to the Executive Committee report? Everyone is clearly very satisfied today. So thank you, Hayley. Much appreciated to you and indeed all members of the Executive Committee. So that brings us now to item 1.8 on our agenda, and an important change here, I think, in that we're going to invite Katie Blackburn, the Regional Director of Llais, to present her report. And usually we have this report as the last item on our agenda, but very deliberately now we've moved it up the agenda. Working with Llais is very, very important. Listening to people is crucial if we are to take forward the improvements we want to make. And so giving importance and prominence to this report is, in my view, right and proper. But also, Katie, as well as drawing our attention to anything you want to in your report, can I also ask that you use the opportunity to share any reflections or comments you might have from your work about any other item on our agenda that we have before us today, so that when we come to that discussion, we will have your feedback to consider as part of that conversation and agenda item. So without any further ado, over to you, Katie.
Diolch yn fawr, Carl. Thank you very much. Just to, for those of you who perhaps don't know me, I'm Katie Blackburn. I'm the Regional Director for Llais, which is the independent statutory body with a remit to support and make sure that the views and opinions of patients and communities are heard. And just to be very clear, I'm not part of any decision-making process here today. I hope my report is fairly clear, and I'm happy to take any questions at the end, or if you want to drop me an email, but there are a couple of areas I think would be helpful to pick up. There's various reference in the papers today around the consultation by Hywel University Health Board. I attended the Machynlleth consultation event, and I think it's very, very clear and evident to everybody that there is considerable concern by that community and the community of South Gwynedd and North Ceredigion, but particularly Powys, around the proposal to make the change to stroke services. I think this links back to what Robert Lewis was saying earlier on about the situation, and Dr. Kate Wright, around stroke services in Powys. It's certainly causing a lot of concern amongst the population, aligned with some of the temporary changes with Cymtaf Morgannwg at the moment, and some of the work that's going on with Hereford and Worcester. So just to reassure colleagues that and the board that we too, I too am pushing to try and have a more coordinated approach that listens to that particular community, the patients of Powys. With regard to that consultation, we will be making some recommendations to Hywel Health Board based on what we've heard, and I'm happy to share that with the executive team and the board if that would be helpful. The other engagement event, which is quite key, I think, for South Powys, is the engagement around Neville Hall Hospital. Similarly, I think it's referenced in papers, there was an engagement event in Crickhowell, which was well attended and presented by Anira and Bevan. There were members of the Health Board, Powys Teaching Health Board there. Similarly, we have fed back into that process what we heard at that event. Members can see that I've given you the dates for our next Llais Local, which is in Knighton and Prestine. And as always, any of you would be very, very welcome. Just drop in, pop in. You don't need to let me know, but the dates are there. If you want any more specifics, just keep in touch. With regard to Better Together, we attended every single event that was held. and I attended the 2 deliberative events. I didn't attend the options appraisal meeting, and that was an intentional decision, as CLICE is independent, and it was important that we maintain that independence. And so we didn't feel that it was appropriate to attend that particular session, but we look forward to seeing what the outcome of that was. We're currently recruiting into a direct report to me of Head of Complaints Engagement, Complaints Advocacy and Engagement. So please feel free to share that advert when it comes out. I think more recently, in the last few days, we've obviously been made aware of the ABUS review with Shrewsbury and Telford Hospital being one of the 14 trusts who are being investigated on a rapid investigation basis for maternity and newborn baby care and neonatal care. So we'll be picking that up, but obviously that's a very recent announcement. With regard to the papers, Carl, thank you very much for that opportunity. I'd just like to make 2 observations, if that's all right. On the framework paper, there is reference in there to the duty of quality and candour, but I would make the observation that actually commissioned services are subject to the Citizens' Voice body legislation as well. So it's not just the duty of quality and candour, but also the element that relates to the Citizens' Voice body, and obviously representations and visits and that sort of thing. So that's just an observation. I'm happy to pick that up outside of this meeting. And then I suppose,
Katie,
yeah.
sorry, so just for my clarity, you said on the framework paper, so just
Yeah.
to be crystal clear, so you're
The
talking about
commission.
the strategic commissioning framework
Yes.
at
Yes.
item 3.1. So
Yes.
yeah, we'll definitely pick that up there.
Yeah.
Thank you.
Sorry, Carl. Yeah, that's right. And then on the performance paper, I mean, it's just again another observation as to whether there might be any correlation between some of the statistics and the breaches and some information in other parts of the papers on the reduction of agency staff. So those are my sort of 2 comments that I just put out there. I think finally, Carl, I just on behalf of CLICE Powys and CLICE Wales, also just like to thank Kirsty and Claire and wish them the very best for the future. We've obviously worked closely with Kirsty on the PECs and very, very closely with Claire over the last number of years. So on behalf of CLICE, wishing you both all the very best for the future. Thank you, Carl.
Much appreciated, Katie. Thank you. Colleagues, is there anyone that would like to make a comment come in? So we go firstly to Robert.
Yeah, thank you, Katie. Looking through the issues you've mentioned there under the heading of health issues, as resident of Powys, yes, I recognise all those. The fact that they are fairly regular inclusions in your list, I don't think you should stop listing those. If those are the issues that members of the public feel strongly about. So I just wondered that now that the big difference between CLICE and the previous organisation is, of course, the inclusion of social care services under your remit there. And I just wondered, do you, in dealing, let's say, with poor communication, which was mentioned there, do you meet with representatives of health and social care at the same time? Because that would seem to be an opportunity to, if you like, not to deal with them separately, so that issues of who does what and who is not doing what in respect of specific patient cases could be resolved more quickly. I just wondered if you're taking that opportunity. Thank you.
Would you like me to come back?
Yes, please. Yeah.
Yes, Robert. One of the processes that we have in place is that when we've undertaken a CLICE local, for example, which is the bulk of where we hear what we hear, we pull together a report which details quite specifically, and just to reassure everybody, the specifics are not published as in such blunt terms, but we produce a report that details of specifics. And then we have a coordinated meeting, a stakeholder meeting between the health board, the local authority, the third sector, the volunteers who have actually been involved in that Llais Local and have heard what they've heard, and the staff. And then if there's a particular theme, we might, so if there was a theme around carers, we'd probably pull Creddy in. We sit around that table and we discuss what we've heard, and everybody contributes to that discussion. And as an outcome of that, and communication, as you rightly say, is not unique to the health board. It's unique across, across a number of organisations. But we do that. We pull a report together. We pull an action plan together, and on that basis, we publish that action plan. So that's our key opportunity to have people sat around the table. And at the last Llais Local, I actually asked people if they felt that it was beneficial. We were all very busy, and without exception, everybody found that a very, very beneficial gathering. So yeah, thank you.
And Mick, please come in.
Thanks, Carl. I think Robert's asked my question. I think Katie's asked it. I too was struck by, kind of reflecting as I read Katie's paper. I think in the 18 months that I've been here, wherever class have been across the patch, those issues of communication and access, regularly feature in the report. And I was just looking for some reassurance that, these are intractable problems. The solutions are in better together in a long-term strategic direction. But there was just some sort of systematic approach to looking across health and care for, maybe local, shorter-term solutions. And I think Katie has covered that. But I just thought it was important to make the point because it struck me equally as it struck Robert.
Thank you, Mick. I can't see that. Oh, sorry. Yes, Claire Roach would like to contribute. Please do, Claire.
Thank you, Chair, and thank you, Katie, for the report. Thank you also for your kind words, and it's been a pleasure to work with you and your colleagues in Llais. I just noticed in the report a reference to feedback that patients continue to perhaps not understand complaints processes. That obviously is a concern because we have our putting things right framework. So we need to understand what it is that people don't understand about how to raise a concern with our services. Conscious that obviously you're about to appoint to a key role within your team. And what I would suggest is that once that role has been appointed to, that there is a discussion between what will be Paul Hooton, the new Director of Nursing, and our Head of Quality and our Assistant Director of Quality with yourself and that new person in your post, so that we can really understand what it is that people don't understand about how to raise a concern. Because clearly we have that on our website, we have information available, but there's clearly must be some sort of disconnect for us to understand further. So clearly not for discussion here now. I don't want to take that time up, but I would like to offer that future appointment between our respective teams so that we can further understand that. Thank you, Katie.
So can I therefore ask that we capture that as an action from this meeting, and so that we can be assured as a board that has happened, and that we are together working to improve that communication and that public understanding of how the complaints process works. Thank you.
Carl, would you mind if I just quickly came back on that? Because actually, Claire's raised a very important point, which I'd forgotten to mention, is that I suppose we are also a little bit concerned about, and it's not unique to Powys, stress, but about an over-reliance on digital and digital communication. So that's something that we're picking up across the board. So Claire, I'm more than happy to have a catch up with your successor and the new appointment. That would I'll pick that up as an action. Thank you.
Thank you. And so finally on this item, we go to Hayley. Thank you, Hayley.
Yeah, thank you, Katie. And really important that we pick up that issue around, you know, how we strengthen understanding of how people raise concerns and complaints. Because so thanks for that, and we'll pick that outside. Just one thing from my point of view. Obviously, there's an awful lot happening currently, both in the space of engagement and consultation, but also in relation to your work on advocacy and the planned engagement that you've got. And I just think perhaps it would be helpful just to understand there's a very strong focus around, for example, the Knighton and Prestine area planned for October, but just getting a little bit of an insight about how you're planning that sort of place-based approach throughout the year, so that you are covering the whole of Powys and being clear that we are sort of getting the breadth across the whole county, if that's okay, Katie.
Of course, our plan is to undertake 4 Llais locals a year, which are the 2-week in-depth living and breathing that particular community. We then undertake a further 6 public fora. So we've just been in Llanfair Corinion, so that's 10. And then we've got a couple of others where we'll go in and look at recruiting volunteers. So our aim is that every year we will undertake one of our activities in each of the 13 localities, be that a Llais local, a public forum, or a volunteering event, so that we have we cover something in each of the 13. We'll also be attending, Haney, just for you to be aware, all 13 of the Better Together events. And so we will be using those sorts of events as well. So it's not just our own, it's about how we hear and listen at other people's events as well, what people are saying. So I hope that provides you that assurance.
Wonderful. Thank you, Katie. Much appreciated. And I'm really pleased that we, if you like, have given more prominence and more substance, if you like, to your report and to your important work on our agenda today. But thank you. So item 2 on our agenda refers to the consent agenda. I explained that earlier. Does any colleague want to suggest that any item under section 5 of our agenda be escalated, if you like, from the consent agenda, and be discussed as a substantive item on the agenda today? No, so all of the items, therefore, under section 5 will be dealt with en bloc, as I described earlier. That brings us to item 3.1 on our agenda and the new strategic commissioning framework. Our Executive Director for Commissioning and Performance isn't able to be with us today, but I'm really pleased that a couple of her colleagues are with us, and I think we're going initially to Chris Moss. Please come in, Chris.
Thank you, Chair, and good morning all. My name is Chris Moss. I'm the Deputy Director for Performance and Commissioning. I won't go through the commissioning framework in detail. I'll take the paper as read, but if I may, Chair, just draw out some key points that I'd just like to bring to the board's attention. So in terms of the proposed strategic commissioning framework, which is an appendix within the papers, this is detailing the Health Board's approach to commissioning of delegated services for its population. And some of the key points that I'd just like to pull out, which are in the paper and also within the framework, are in terms of this providing a methodology for how services are commissioned effectively by the Health Board to make sure that they meet the population health needs of Powys, that this is aligned with the principles of the NHS Wales duty of quality. And Katie, thank you for your very helpful feedback. We will make sure that we reference also within the framework in terms of the legislation from a Llais perspective and the citizens' voice body. So thank you for that feedback. It's also, Chair, drawing out how we propose to make sure that the Health Board's resources are used wisely to make sure that we can get the best possible outcomes in terms of quality and experience for the population that we serve, provides a clear evidence base to make sure that we're making informed decisions, and outlines within the framework that we will be developing or looking to develop an annual commissioning plan that will support the Health Board in terms of the sustainability and recovery and level 4 de-escalation criteria through the delivery of the integrated plan, which, as we all know, responds to the strategy, the NHS Wales planning framework and ministerial priorities. Now, in terms of the scope of the framework, it's detailed within that this will apply to Powys commissioned and provider services, but does not apply to primary care, continuing health care, or mental health out of area placements. As per some earlier discussion, the framework does include and does apply to services we commission from the third sector. And it's proposing that we move more towards being a strategic commissioner and away from the transactional contracting approach that we have currently, and to a more strategic approach based on the health needs of the population and how we can improve outcomes and support recovery and sustainability for the Health Board. Within the framework, we are referencing an NHS Confederation report on the vision for integrated care boards in NHS England, and we've utilised that to provide us with a bit of a framework for strategic commissioning for making decisions of commissioning of services and treatments. We've also designed the framework to ensure that the Health Board will act in accordance with an agreed set of principles when making decisions around the commissioning of services, and that these are underpinned by criteria that are aligned to the Health Board's health and care strategy. We're also proposing within the framework a commissioning cycle that sets out a range of activities to effectively commission, and that would be under the headings of strategic planning, service, design, and assurance and evaluation. And there is detail within the framework on elements that sit under each of those three domains. And we're defining expected outcomes in line with the Healthier Wales quadruple aim and the associated performance measures contained within the NHS Wales performance framework, prudent and values-based healthcare principles. The framework also describes the roles and responsibilities of all staff within the Health Board, that we feel that commissioning is everybody's business, and is setting out how we will govern the governance arrangements, that will be put in place to provide oversight and assurance with reference to the Better Together programme, and then internally within the Health Board, the Commissioning for Value work programme, the Integrated Quality and Performance Framework, and the Commissioning Oversight and Assurance Group. We have undertaken a delivery confidence assessment against the competency, capability and capacity for us to be able to discharge our responsibilities under the framework. And we've identified that we're very strong in terms of performance management, elements of the framework and contracting, and we're making good progress in terms of referral optimization and data analysis. But we have identified there are some opportunities for us in terms of improvement in population health assessment and evidence appraisal, and how we can utilise transformation resources to drive pathway change and referral optimization at scale. Just to finish off, Chair, in terms of implementation, we are proposing that we will phase this aligned to the delivery of the annual plan for 25-26 and for the development of the annual plan for 26-27. Alignment to Better Together programme. And as I said earlier, we will be developing an annual commissioning plan detailing the actions to be taken forward, and as Hayley had indicated earlier, how we intend to prioritise these to ensure alignment with the annual delivery plan. Part of this will be the development of commissioning intentions for 26-27, which we propose to present for further discussion at a board development session. And within that, we will be looking to ensure how the Health Board can commission within resources and how we can look to manage demand pressures within available resources to us going forwards. I'm conscious that's a very quick canter through the framework. Hopefully that's been a helpful oversight, but I'm very happy to take any questions.
Very helpful, Chris, and thank you for that, and indeed for the document itself. So a few colleagues would like to contribute. So we'll go firstly to Robert.
Thank you, Chris. It's a big document. I think most of us will agree with its content, and I assume we're doing a lot of this already. but I do have one further comment and two questions. The first is we're not in a buyer's market for services. It's not as if we mostly have lots of choice of whom to commission, but in principle we do have a choice of what to commission. And you mentioned prevention in the document. It's always been, of course, one of our aims. And with increased expenditure on prevention, many services will hopefully become sustainable, or as I would like to say, affordable in the future. I think we're returning to prevention in one of our development sessions soon, and this will be very important in influencing our annual plan. Now, my two questions. Why is primary care not part of this framework? And second, have other health boards or trusts adopted a SCF? And if so, what substantial added value did it bring? Thank you, Chair.
Thank you. Chris, can I suggest that we, because we've got a few, we take a couple of colleagues' contributions and then we'll come back to you. So we go now to Simon.
Thank you, Carl. Simon Wright, independent member. Echoing Robert's comments around how helpful this is and seeing this is really codifying quite a lot of existing practice is my expectation. It quite properly puts a lot of emphasis around data and performance evaluation. And so my question is, how confident are we that we will have access to that data, particularly from providers across the border, and in the context of those known issues around data from some of those providers being problematic for us? How would it help us make sure we've got the right data to make the right evaluations? Thank you, Chris.
Thank you. And we'll invite Steve also to come in now. Please, Steve.
Thank you. Yes, Steve Elliott, independent member for finance. Echo again what others colleagues have said around the document, and it's a really useful framework. Particularly pleased to see an ambition to do work around population segmentation and also introducing use of programme budgeting. What's missing for me is more detail around how we will look to implement the framework, and particularly how the framework will support our need to improve our financial sustainability. So I think particularly in terms of needing some more detail around the services that we will concentrate on first, milestones for delivery, etc. So looking for some action there. And also in terms of programme budgeting, whether some ideas have been coming forward in terms of the areas that we would look to introduce programme budgeting first. Thank you.
Thank you. And finally, before we come back to you, Chris, we'll invite Mick to come in.
Thanks, Chair. I think it's kind of building on Simon's and Robert's question. This is very welcome, and it seems to make sense, and it's a it's a very important strategic shift which supports better together and long-term strategy, but it's quite a significant change. So just picking up on that point that Simon made about needing to have the right data and the right intelligence, we also need to make sure that our staff have the capacity and capability to implement the changes, that the cultural change that needs to take place to move from a reactive to a proactive approach is in place. So just looking for, alongside those other questions, some reassurance that this is not a kind of process driven, the people and the system aspects are also reflected in the implementation plan.
Chris, that's a lot in one chunk. I appreciate that, but please do come back in.
Thank you, Chair, and thank you all for the questions, which I'll take in turn. And if it's okay, I might well ask colleagues to contribute as well to some of the questions. Robert, thank you for the questions, and agreed in terms of that focus within the framework in terms of prevention. In terms of the exclusion around primary care, if it's okay, I know Elaine that you'd wanted to comment on that. So if I can bring Elaine in at that juncture.
Yes, absolutely. Thank you. Hello, everyone. I'm Elaine Lawton. I'm the Director for Primary Care, Community and Mental Health. And I think I'd extend your question, Robert, actually, in terms of primary care, complex care, and the mental health external commissioning isn't included in this. And I think that's because historically we've had very different and separate ways of commissioning these services. There's legislation related to CHC, continuing healthcare, and in terms of primary care, our responsibility is around ensuring that there is provision for those services across all of our population, provided locally wherever we can do that. But I think it's a really interesting observation, and one that I'm going to take away from this board meeting and pick up separately with Chris around how maybe we need to develop and include something around primary care, continuing healthcare and mental health commissioning as part of this strategic framework.
Thank you, Elaine. If I come back to the questions raised as well, then, Chair, if I may, in terms of, Simon, thank you for the questions. In terms of the data issue, I think we've got reasonable assurance in terms of receiving of that data. There are some difficulties, as you know, that we've encountered this last year with some data from certain providers. So I think generally we're very confident that some of those issues that we've highlighted have been rectified by those providers. We are in conversation with them at the moment in terms of the requirements of the strategic commissioning framework and what we will be looking for going forward. So at the moment, I think the issues that we've highlighted previously have been addressed, and there's nothing problematic aside from one issue that we are working through at the moment, which is around the robustness of data we have on referrals from primary care. So we have identified some discrepancies within data sources that we have access to, but we are addressing those at the moment. That would be the only data issue, I think, at the moment that we would we'd seek to highlight. So I think we're confident in terms of that that data that we receive, and there will be a data issue I will also reflect on later in terms of the IQPR month 4 report, which will go into that a bit more detail as well, Simon. So thank you for the question. Hopefully that provides you with that assurance. Steve, thank you for the question in terms of how we implement and in terms of the milestones and services. Yes, completely agree. We would be planning to provide that additional level of detail within the annual commissioning plans that will form part of this framework going forwards. So we would be looking to be extremely clear on the areas that we will be addressing, our expected outcomes and the timescales, and a lot of that as well, as Steve, will feed into the discussions around the commissioning intentions that we're developing at the moment, which will provide the increased level of detail that I think you're requesting, that's currently not in the framework, but will be included in terms of the annual plans that we produce every year. Does that answer your question, Steve?
Yeah, I was probably hoping for something a bit sooner than the production of the plan, but if that's the mechanism that we're planning to use, then okay, thank you.
There are some key deliverables at the moment that, as I say, are being pulled together, which will be presented to the board development session, where you will be able to see some more of that detail, and that's been presented, I believe, in October. So you will see some of that immediate thinking very soon. Thank you. And Mick, oh, sorry, Steve, I haven't addressed your issue in terms of programme budgeting. In terms of areas to explore, that will again be picked up through some of the commissioning intentions, and also then through the annual plan that we will look to produce. So yes, that is in hand. Apologies, I didn't answer that question. And Mick, lastly, thank you. In terms of the process, yes, we will be through that competency, capability and capacity assessment. We will be looking to pull through those issues to make sure that we do have sufficient capacity to be able to implement the framework going forward. And as I've indicated, there are some very good, positive areas at the moment, but there are some areas where we just do need to address to make sure that we have the full capacity and competency going forwards, to make sure that, as you said, there's effective involvement of people and systems in taking forward the framework going forwards. Have
Thank
I
you, Chris.
covered, Chair, all the questions? Apologies if I have missed any questions from colleagues.
I don't think you have, but colleagues will indicate if they think that they want to come back or rather continue the conversation with you, or feel that their question hasn't been fully responded to. But I can see that both Mererid and Hayley wants to come in. In terms of which first, I don't mind. Hayley, do you want to come in now, or would you rather wait until the end?
If that's okay. After Mez.
After Mez, okay.
Yeah.
Okay, thanks, Mez.
Diolch yn fawr, thank you. So I just wanted to come in on the prevention, and I know we're going to be discussing the framework next, but actually they do go sort of hand in hand, if I can use that sort of phrase, that as part of the commissioning pathways, we should be embedding prevention across the pathways. So whilst my framework talks about primary prevention, I also make reference to when people develop conditions or diseases, it's important that we support them to manage well. And whether that's in primary care in Powys or if it's commissioned out through secondary care. Equally, what the annual report also shows is that what are the main diseases affecting our population, and in turn then what are we commissioning? So Nicola and I have had conversations around how do we develop and embed that prevention across the pathway. And as Chris has mentioned, this will be a team sport across the execs, and I will be having a public health consultant who specialises in healthcare public health as part of that commissioning framework group. Hope that's helpful.
It is helpful, Mererid, and I think joining those dots, as we talked about earlier, and making sure that everything is works as part of the same system, as it were, is crucial. So, but finally to you, Hayley.
Yeah, thank you, and thanks to Chris and colleagues for responding so far. Just a couple of reflections. So the first thing to say is this is a blank sheet of paper we've been commissioning for years, and this is an attempt to try and describe the processes that we want to continue going forward and give that overall approach. And I think there's a couple of reflections from the discussion. Obviously, Kate's point earlier, you picked up, Chris, around reflecting the citizen's voice aspects, and then also I think that what I'm hearing from the conversation is being able to really clearly value and financial sustainability is something that's referenced in the document, but potentially we need to just up front talk about that in terms of the choices and commissioning within resources context that we've got. The broader question that I think Robert raised, which is about do other health boards have a strategic commissioning framework and what's the added value of this? We all call things differently. People have got commissioning approaches that they've agreed organisationally, but for us, because of the scale of commissioning, we need something much more wide-ranging in terms of our approach, and we have benefited previously. Historically, we have had commissioning assurance arrangements in place, and that has brought a number of benefits from my perspective. The first one being that we look broader than just traditionally perhaps contractual discussions around finance and access targets, and we're bringing into that consideration governance, quality and outcomes. So I think from our own lived experience in Powys, we've had benefits previously from setting a clear framework to work within, and clearly if we compare with some of our neighbours in England, that's quite interesting as well to look at some of the approaches they've got around the frameworks that they commission to, and I think that we've drawn from some of that evidence in our thinking around this to try and consolidate an overall framework that doesn't need to change every week, but actually gives us that overall direction of travel. What I'm hearing from colleagues is further assurances needed around implementation and how we move forward with this, and in particular how that then relates to primary care, continuing healthcare, mental health, and more broadly, we've just talked about in my first report, the third sector review. So I think there's something very important that the commissioning framework wasn't to give everything around the implementation, but I think what I'm hearing is the board needs further assurance around the implementation planning against the framework in the organisation, and I think we can do that through reporting as we proceed later this year. I think Mick's point is really important around culture and changing our focus, and in particular making sure we've got the right skills, the right competency and the right capacity to take this work forward. So just some reassurance, the 3 C's assessment, as Chris mentioned, has been undertaken, but we have identified gaps, so we will have to find ways to address that as a collective board, but also as across the whole organisation, and that will be part of the implementation planning that we're going forward with. So my suggestion, Chair, is that with some additional sort of amendments, particularly around the citizens' voice and the connection to financial sustainability, that we would bring further assurance to the board or to the relevant committee first on the implementation plan against the framework, to pick up the additional issues that have been raised with regard to how that fits overall with other aspects of our work. Thank you.
Yeah, thanks, Hayley. So can I just be clear that so from our discussion, there seem to be some things that yes, there's the implementation plan that we've discussed and the importance of that, but there are some things that may well need amendment to the actual framework itself. So we've talked about the consideration of inclusion of primary care, CHC, mental health. We've talked about including the citizen voice regulations. We have, and so there are some things there. So I just wanted to be clear about approving the document today. I don't necessarily suggest that it needs to come back to us, but how, Hayley or Helen, how do we as a board manage approval of this document if we are also saying that we would like certain amendments made? Helen.
I'll offer a suggestion, if I may. I think if the board are content to approve the framework subject to those points that are made, I think in the next chief executive update in November, Hayley, if she was content, could provide an update of the amendments that have been made and the progress that's been made. We then need to look at our general routine reporting in this against this framework anyway, so that suggestion can come back to board as well. So I think it's whether or not the board feels that it is substantive enough to approve today, subject to those amendments, and then a timely report in November.
Thank you, Han. That's really, really helpful. So can I suggest, colleagues, that we proceed in accordance with Helen's suggestion and advice, but please do come in and indicate if you think otherwise. So essentially, we are approving the document today. We acknowledge that it will undergo further amendment in light of and as a result of the discussion today, and through the Chief Executive's report to us at a subsequent meeting, we will receive assurance that those amendments have been made and have been incorporated. And of course, we will also be cited on the implementation plan and the implementation actions associated that fall out of this particular framework. So colleagues do indicate, but no one is indicating, so I'm assuming that everyone supports the approval of the document with those caveats and qualifications. Chris, thank you so much, and to your colleagues. A really, really helpful document, a good framework, and always a work in progress, I know, but as I say, thank you. Which takes us then to item 3.2 on our agenda, and we're back with Mez and the Population Health Strategic Framework.
Diolch, Cadeirydd. Thank you, Chair. Can I just also, there you are, Stuart's on screen as well. Welcome, Stuart Bourne, Consultant in Public Health, joining me for this item. So, okay, bore da. So I'm pleased to present my annual report, which is also a framework for population health for Powys. So important to highlight, this is the first primary prevention framework for the Health Board, which we have entitled Preventing the Preventable, and it is focusing on primary prevention. So the framework takes an evidence sort of approach and is structured around understanding the health of the population. So how healthy is the population of Powys? What are the causes of ill health? What are the main diseases experienced by our population? And of these main diseases, what are the risk factors, and can these risk factors be prevented or modified? And if they can be prevented or modified, are there evidence-based programs or interventions, if applied at a population level, that could improve health of the population? And the aim then of the framework is that more people spend more years in good health and live longer. So in terms of chapters within the report, so the first chapter, we've set up the demographics of the population of Powys and describing the building blocks of health and what contributes to make us healthy. So as the population of Powys is living longer than the population of Wales as a whole, with life expectancy on average being 83 years and 4 months for women and 79 years and 5 months for men. Not all of these years are spent in good health, so it's absolutely great that we're living longer in Powys, that's great, but important to highlight that not all of these years are living in good health. And women will live on average around 19.5 years in poorer health, and males around 15.5 years of their life expectancy in poorer health. But also to highlight that some people live longer, healthier lives than others, simply because of the conditions they were born into, they grow into, or live in. And these conditions can make it harder for some people to stay healthy or get the care they need. And those born in the most deprived areas of Powys spend fewer years in good health compared to those in the least deprived. An example of this is highlighted in the chapter 1, where males in most deprived areas live on average a third of their lives in poorer health. And we refer to this as health inequalities, which are unfair and unjust. And then when we've looked at chapter 2, some of the population are developing chronic conditions and illnesses earlier than others, and some people are also sadly dying too young. So in chapter 2, we've set out that 2/3 of early deaths, and that means deaths sort of under the age of 75 years, are caused by 3 chronic conditions, and these are cancers, heart disease and stroke, and respiratory diseases. So these conditions are not always inevitable, and that's the important point for us to, as a board, to understand. The conditions also share the same or similar risk factors, and some of which are preventable. So we've identified those risk factors that could be modified or prevented, such as health behaviours, including smoking, healthy weight and diet, physical inactivity, and alcohol consumption. And then we've identified, and my thanks to colleagues, and Tracy Deacon's not with us today, but also colleagues within the Public Health team, and I've recognised in the report also from colleagues from Public Health Wales who've contributed to the evidence base to identify those evidence-based interventions that, if they were applied at a population level, that could improve population health. And we've set these out within the report across the life course approach, and that is start well, live well and age well. And that lines back to our strategy, and board members will be familiar with the RPB structure there, where we have groups start well, live well and age well. So I'm going to pass to Stuart now, who's going to talk a bit more about the evidence-based approaches that we've applied to the document. Thanks, Stuart.
Yeah, thank you, Mez, and thank you for the opportunity to talk about the framework this morning. As Mez has alluded to, we've tried to take, when we have developed the actions for the framework, what is called a return on investment approach, and that's described and summarised on page 12 of the framework document. But essentially what we have done is we have gone out and we've looked at sources of evidence, research papers, where we could find some economic modelling of those interventions and where they had used a return on investment methodology. And typically what you find in that type of research is a statement that says for every pound spent, you get X in terms of return. The important bit just to say about return is sometimes those are cashable returns, if I use that phrase, for health services, but sometimes they aren't, and in fact often they aren't, and it's important to understand that. Sometimes it's about slowing the rate of growth in demand, so the trend is ever increasing growth, and these interventions help to dull that line of growth. And then the other area of return obviously is the broader benefit that we derive as a society from having people in our population that are fit, healthy, able to contribute both economically but socially, etc. as well. And that can be costed and is costed in a lot of the research. So where we have the actions that we have listed, we haven't actually put for every single action what that return value is. What we have got for each of the actions is the references, and that will, if you went to those source papers, is where we have got the return values from that have generated their inclusion in the report. So we haven't slavishly put for every single action there's a return of £10, £20, £30, etc. But what we have got is the underlying references by which we can derive those values, because that's where they were based in the evidence when we put them together. I think the other thing, just to finish on the return work, is we do recognise in public health that not everything has had a return value done that may be of value, but a lot has. And taking an economic lens for this work, we recognised that it was important that we focused on those areas where we had got evidence of economic value for what we were doing, given where we are. But we also acknowledge there could be and probably are areas of work that haven't gone through this particular methodology that could be of merit as well.
Okay, thank you, Stuart. So yes, happy to take any questions if that's helpful.
Yeah, thank you both. And so I can see that some colleagues want to contribute. So again, I'll invite a few contributions, and then we'll come back to Mez and Stuart for a response. But we go firstly to Simon.
Thank you, Carl. First and foremost, thank you for what I found to be a really, really helpful report. Really well set out with some really clear visuals. So huge thanks to everyone who's contributed to that and pulled it together. I thought it was a really excellent piece of work. It's really, I think, Stuart, picking up on some of what you touched on towards the end there. There's a lot of recommendations for action here, which is great. At some point, there will need to be, I assume, some kind of prioritization and funding to take forward those actions. So I think one of the things I'd be interested in understanding is how do we use the evidence base, and it's excellent that it talks about that return on investment. I've got some assumptions around that return probably having a time lag, and we've got immediate, some very real and acute financial pressures in terms of service delivery now. So how do we use this kind of report to help us make the best decisions around our commitment to shift to the left, to make prevention real, and to realise the benefits of doing that in terms of the longer term sustainability of our financial position as a board and of the services we deliver. So I'm just really interested in how do we move on from this really, really helpful report into those actionable decisions investment plan with a clear line of sight as to what we think the returns will be and when they will come through from the kind of decisions we will need to take around how do we take forward the prioritisation of the actions proposed in the report. Thank you.
Thank you. Steve, please.
Thank you, Mez and Stuart. I think I mean, the first thing I'd like to say actually is how refreshing it is that we've been able in this board today to have a much bigger focus on prevention than maybe we normally have. And I think that even goes back to the patient story where where we heard about how pulmonary rehab was helping that individual avoid medication. So I think that's really good. And echo Simon's comments around the report and how helpful it was and how well structured it is, and particularly like the use, Stuart, of the return on investment methodology. To be honest, it's a similar question to Simon, really, in terms of there's 112 actions in the report, and clearly there's a need to focus on those that are going to have the biggest impact for the resources applied and the need for a prioritisation approach. So it's not really a new question, but I just wanted to welcome the report as well. Thank you.
Thanks, Steve. And to Kirsty.
Thank you. And like others, I just want to thank everybody involved in producing the report for what is a really comprehensive and excellent document. I guess for me, there are three issues. The first is, how do we carve out in the significantly challenging financial circumstances that the organisation faces, resource to invest not only in our own teams but also in programmes that can deliver. And how do we do that collectively as a board, support that when perhaps lots of the other pressures are driving us to spend money in other areas or not spend any money at all. So I'm just wondering, how can we collectively as a group of people stand behind this work? And secondly, one of the things that, forgive me if I've missed it, but a lot of the stuff, it seems to me, also hinges on our ability to engage our population and to have a population that is health literate so that they can make the positive choices that we know will make a difference to themselves and their families' health. And how can we support that? Because there's lots of initiatives, but sometimes I do wonder whether we're preaching to the choir and we are potentially engaging with people who would have engaged and made some of those choices. So what I didn't see in the report is, what is our approach to supporting and developing the health literacy of our local population? And that ties to my final point, is then how do we counteract misinformation in this agenda? I'm particularly concerned around vaccine. We have seen yet again this week in another country, but we know that those messages will be picked up in our own country, a non-scientific proclamations around the safety of vaccines. And we know that vaccines is one of the most cost-effective and effective way in which we can prevent ill health in our population, and we've seen an assault on that again. So what can we do to not only increase health literacy in our population, but how can we counteract misinformation that may be preventing people from accessing some of these approaches to prevention? Thank you.
Thanks, Kirsty. So we still have some other people wanted to contribute. Colleagues, I'm conscious of where we are on the agenda. We are behind where we were scheduled to be at this stage. And so I'm not, this is a really, really important report, very important discussion. All that I'm asking for is, perhaps a succinctness, if that's possible. So we go to Mick.
Thanks, Chair. I can be succinct because my questions have been asked and answered around return of investment and prioritisation. But I just want to pick up on the quality of this report. As you read through the papers, you suddenly get to this point in them where it suddenly becomes light and accessible and readable. And I found myself wanting to kind of go into the report. In contrast, this is no criticism of other reports to others. This is really important stuff, and it's at the heart of Better Together. It's at the heart of our long-term strategic ambition. That message needs to get out there. And, I just wonder what we can learn from the way that this report is presented, in such a digestible and, almost interactive way that makes you want to read it for the rest of our external publications. Because if we produce and no one wants to read them, what is the point? I just think there's something here about, a Powys house style, which is really powerful that we could build on.
Thank you, Mick. Helpful. So Robert and then Elaine.
Thank you. Just to note that many of the actions that follow from this report will, of course, involve other organisations as well. So Education, County Council, and also that some of the actions are already reflected in our existing plan, vaccinations, healthy weight, cessation of smoking, and so on. We can, of course, be as revolutionary as we like, or as we can afford, or whatever the constraints are. And we are going to have, I think, an away day to discuss this. But as a minimum, I would expect that some further actions would be embedded in our annual plan for next year. At the very least, some additional actions which we are confident we can make a difference without perhaps spreading ourselves too thinly. And just finally, Mez, and this is my fault, when this came to PPPH, I didn't mention this, but we had agreed that we would try to qualify the position of Powys in respect of other parts of Wales by also identifying other places, this is Ronnie's South Devon or whatever it is, which is a fairer comparison on, how long people live and how long they live healthily and so on, to try and inform us as a county and as a health board, to try and inform exactly how well we're doing, because I think we'd be very surprised if Powys wasn't at the top end of any statistics. Thank you.
Yeah.
Thanks all. So Mez, Stuart, please do respond. Again, please don't feel you have to go into every detail, but a brief response from yourselves, please.
Okay, thank you. We'll do a double act between us, if that's okay. So can I just say thank you, first of all, for feedback and comments, very welcome, and I will be feeding that back to everybody involved. And as I mentioned earlier, it's important for me that to acknowledge everybody's contribution to the report. Okay, so prioritisation of actions, yes. So one of the things I think as a board that we will be having a discussion as part of development of the next year's annual plan. So it's important for me that there is board involvement in that prioritisation. I think we all know, don't we, really, that the acute healthcare pressures are just not now. They've been growing for a while. And I think from this report, it's inevitable that there will be continued growth in those acute pressures, but unless we start to shift left. How we do that is a collective sort of challenge for us as a board. So as part of the annual plan and the IMTP, every year, the first pillar of that of our plan is well-being and early intervention, and you'll be familiar with some of the actions that we agree to put in there on an annual basis. What this framework does is, if somebody was to ask me prior to today, well, actually, what's your population then prevention approach and strategy? Well, it's not strategy, a framework for Powys. We didn't have one, so this is the first one, which helps then inform that strategic direction to explain, well, these are our major causes of diseases. These are the interventions. Should we roll them out at population level, that could improve population health? So that would be the sort of discussion that we will be bringing into a board development for a collective discussion. Just want to highlight as well that you know, sometimes we talk about prevention being long-term and medium-term. In terms of early years, a pregnancy is 9 months. We can affect change within 9 months. Equally, last year we rolled out the RSV vaccination, and Scotland did roll that out a bit earlier than Wales and showed a clear impact on hospital admissions in the age group that were eligible for that vaccine. That was within 2 to 3 months element. So, so there are actions, and I've mentioned sort of early years there. Within the report, we do talk about giving children the best start in life, and important for us as a health board to have a focus there from a prevention to prevent those illnesses or problems from arriving even at sort of school age. Our members will also be familiar with our childhood obesity work in terms of weight management that we do know. We've had work going on in that area for the last 2 or 3 years, and we have seen a decline there, which is good news, but still 20%, over 20% of our children at age 4 or 5 are overweight or obese. So there'll be some things around the discussion of what are we doing that having an effect, but actually can we go harder? And if we did go harder, actually could we have better sort of outcomes there? Stuart, is there anything you should come in on? I know I haven't answered all the questions, but don't want to hog all the questions either.
I think the time lag point is a very good point. It's often a trade-off. You get a higher return with a longer time period with some of these interventions, and that's just a consequence of the effect that it ripples through a life course. But there are absolutely some actions in here, and you've alluded to 1 or 2. That, you know, falls prevention programs in older people. I think within 18 months you start to get a return on that investment. Some are a little bit longer, so there is a mix. But it is a balance, isn't it, between scale of return, how long it takes you to get that return, and there are other things as well around. Is it going to impact whole population? Does it affect inequalities? So there are other measures, and the point also that this is both actions for a broader partnership and a system. We can't deliver all of these solely, but there are some we can. And for those that we can, I think those are the ones that as an organisation we should be looking at in the context of IMTP next year. And again, we are doing a lot of those actions you would say are in place, but there are things about, are we doing them in scale or even in the right kind of way based on what the evidence says is best effect in terms of intervention. So even with the things we are doing, there's no reason why we shouldn't be just understanding that we're doing those to the maximum and that we're doing them in the right way to deliver the outcomes that we want to achieve. So I think that's a fair point, but that's where I think we need to go next. I will just note, just on the health literacy, just to note it is lost, I know, because of the number of actions, but we do pick up health literacy. I think on in the Live Well section, there is an action there under page 35 about developing and implementing health literacy programs, because I do agree strongly with Kirsty, that's an important one, and I can't quote the return, but I know it was quite a significant return on that as an area of work, so I would endorse that as being an important area of action within the plan based on the return at least. Thanks, Amaz.
Thank you all. I think the discussion has very helpfully and rightly highlighted not just the interest in this report, but a real commitment to its importance, its strategic importance for us as a board. And you know, we just want to say a big thank you for that. Mick very helpfully, I thought, expressed appreciation for the format of the report and the way it had been written and presented, and suggested that we learn from that in a wider way, and we'll certainly do that. So a big thank you, and we look forward to its implementation, and particularly as we come together in board development session and as we begin to consider our plans for next year and beyond. So diolch o galon. We are then asked to discuss the report. I think we can safely say that we've done that, and to approve the framework. If anybody would like to indicate that they don't support that recommendation, please do so. That therefore is supported unanimously. Colleagues, I'm going to suggest that we take our break now before we come to item 3.3. Can I ask that we take a 10-minute break, and so we will reconvene at somebody do the time maths for me. It's now 25, so we will reconvene at 11:46, so just after 11:45. Thank you. Croeso nôl pawb. Os ga i jyst gwirio bod pob un wedi dychwelyd a bod ni yn barod i ailgychwyn. Just want to check that we have everyone back in the meeting and that we're okay to reconvene. Can somebody just indicate that we're good to go?
We're good to go, Carl. Good to go.
Okay, thank you very much. So we turn now to item 3.3 on our agenda, to the Director of Corporate Governance report, and to Helen. Thank you, Helen.
Thank you, Carl. Morning again, everybody. So a slightly briefer, but with some important items in my reports today. So firstly, you'll see a summary of the board activity that has taken place since our last report on the 30th of July. And importantly for members of the public, the summary of our in-committee agenda appears in my report as well for public awareness. Board committee membership is the second item. You approved membership as a board back in July. Invariably, some changes take place throughout the year. We wouldn't report every detail of those. But Carl, earlier in the meeting, you referred to this being Kirsty's last meeting. Not only is she our vice chair, importantly, she chairs our Patient Experience, Quality and Safety Committee. So with thanks to Simon Wright, as your request, our independent member, Simon will pick up the chairing of that committee whilst we're in the process of recruiting an additional independent member to be our vice chair. So thank you to Simon for that. The Healthcare Professionals Forum, we've been a little bit delayed on this. It's coming to the board a little later than I intended earlier in the year, so apologies for that. But I'm pleased to now provide you with the draft terms of reference. They are largely based upon those copied in the model standing orders. This is an important advisory group to the board that will now be established and will provide our clinicians with the opportunity to be able to advise the board on their professional and clinical issues. So the terms of reference is provided. We anticipate the forum meeting 4 times a year, more often if needed. And you'll see in my paper, it refers to the fact that this will operate alongside our clinical reference group in our Better Together programme. Just to be clear on that, it is a separate group. This is an advisory group to the board in its own right. It will be an associate member that will chair this group and will be approved or asked to be approved by the Cabinet Secretary for Health and Social Care, as indeed are all of our independent member public appointments. But what we mean by running alongside is we only have so many clinicians and so many members of staff in the organisation. So we will make best value of our timing and our organisation that sits around those two groups. The terms of reference are subject to annual review, as are all of our governance documents in that context. And then finally, in my reports, you can see the summary annual review of our petitions protocol. This was put in place for the first time back in 2024. This is a assurance and compliance reports to the board, as was promised in that protocol on an annual basis. You'll see in there that I'm not identifying any areas of non-compliance, and there is a report of the petition that we've received, but also those that we have been aware of, but not necessarily received, and where we have also contributed to the petition received through the Senate Petitions Committee. Just lastly, we have been offered the opportunity to contribute to the procedures that are in place for the Senate Petitions Committee, and we've provided our feedback, as you can see, through the NHS Confederation. So, Carl, very happy to take any comments or questions. Thank you.
Much appreciated, Helen. Just whilst people are considering whether they want to comment, really pleased to see the terms of reference for the professional forum. In terms of the timescale for this, Helen, clearly the forum will need to identify its own chair and vice chair, as you say. The chair will be would be a recommendation to the Cabinet Secretary. But when do we envisage that the forum will actually be up and running?
Yeah, thanks, Carl. So no later than the end of this calendar year, sooner if we can. We're working hard on membership now and trying to make sure that we've got all of those details and plans in place. So no later than the end of the calendar year.
Thank you. Simon, please come in.
Thank you, Chair, and thank you, Helen, as always, for your report. It's a minor point, really, on the terms of reference for the Healthcare Professionals Forum. Just there seems to be at 1.2 and 1.4 a repeat of does not include consideration of terms and conditions of service. It just seems one of those possibly could go. It's just a minor point. Thank you.
Thank you for spotting it. We'll sort that out.
Thank you. So, colleagues, let's come to the recommendation, which is that we receive the Director's report. We note the changes to the board committee membership. We approve the terms of reference for the new Healthcare Professionals Forum, and we receive and take assurance from the annual update on petitions that we are compliant with our own protocol. So, colleagues, does anyone want to indicate that they don't support the recommendation or that they would like to comment on the recommendation? Therefore, that is approved unanimously. And a big thank you, Helen. Which takes us to item 3.4 and to the minutes of our previous meeting that have been circulated for accuracy. Are there any changes to the minutes that anyone would like to suggest? No, so we adopt those as a correct record. We have been through our action log, but are there any other matters arising from those minutes that we haven't captured in the action log? Simon.
Thank you, Carl. There was a couple of issues raised in the minutes. So at 3.2, the issue of the Wye Valley invoice. I just wondered whether that position had progressed. And at 3.4, the challenges around data from Shrewsbury and Telford. And I wondered if there was any update on progress with resolving those issues as well.
Thank you. Hayley, would you like to nominate one of your executive colleagues to respond to Simon's questions?
I'm happy to come in. I'd have to check with Chris the date, but around the data issues with SAF. But in terms of the Wye Valley Trust invoices, no further update. We have escalated the matter, but we have had no further update from colleagues with regard to that. And in terms of the data, I know that that issue is now with a date for it to have been fully resolved. And Chris, just wanted to check, we've had the first cut of that information. Is that correct?
Yes, I think it is, Hayley. That's right.
Great. So on an ongoing basis, we'll be validating now the backlog of that information, but hopefully that issue is resolved going forward.
Thank you.
Thank you very much. There are no other matters arising, which means that we turn our attention to item 4.1 and to the presentation on our Better Together programme. We'll ask Deb to lead on this, and I think that Lucy and Adrian are also going to support this. Thank you, Deb.
Buradar, everybody. Thank you, Chair. Deborah Wood-Lawson, Executive Director of People and Culture. As you've rightly said, there are slides in the pack to support this item, and it provides a brief update on activities and particularly the engagement events that have taken place since July, which is when we brought the last board report. There's been an incredible amount of work already taken place on this first phase of the programme, which focuses on inpatient services, urgent care, mental health, and some community-based services. We know that engagement with all our stakeholders is essential to ensure that we hear their voices, can consider their ideas, and support understanding of our future emerging options. And just looping back to something that Katie from Fly said earlier in the meeting, we do recognise that our first stage had a conscious decision around using digital, but it was supported by face-to-face events as well. However, looking forward, and again, to assure board and stakeholders that during any consultation stage, that there will be significant opportunities for face-to-face events and conversation. So in summary, the paper highlights some of the recent activities. So just as a canter through, a deliberative event took place with staff, public and partner representatives in August. An engagement outcome report on stage 1 and stage 2 engagement will be presented to board in the autumn. Detailed clinically led design work has taken place over that period, including a lock-in week, primary care workshops and an options appraisal day. And we have previously reported about the external commission support for engagement and consultation. ORS will support us with kind of independent delivery, and HICO are in place to provide independent assurance for stage 3 consultation. So in conclusion, good progress has been made against an ambitious timeline. Clearly, the programme is not without its risks, particularly around our clinical and corporate team capacity. And I would like just to put on record our thanks to those teams who've gone above and beyond on their work on this programme. That was probably all I was going to say on the report. I'm happy to take any comments. Thank you.
Thank you, Deb. So can I just check, Deb, are Lucy and Adrian contributing or not today? They're not.
Not necessarily, no.
Okay, absolutely fine. So does anyone want to contribute at this stage in response to this agenda item? Please come in, Ian.
Thanks very much, Chair. And yeah, good update, Deb. Thanks for the paper. I just would like you perhaps to give us a bit of your oversight into how things have gone with the programme so far, and the kind of levels of engagement, and how staff in particular, from your point of view, are feeling about the whole process, just so I think board can have some insight into the way this thing is actually working for real in people's lives. Thank you.
Okay, thanks, Ian. Really good question. In terms of oversight, it took us a little while to put in place our kind of governance arrangements, because we needed to deconstruct some of the previous arrangements, so it's taken a little while to form. I chair that board. It has a significant number of work streams behind it. What I would say is that momentum has built. And there are daily kind of meetings taking place. What it does do is it does provide quite a conflicting position across the range of priorities, better together just being one of those. So we're carefully balancing those resources and those priorities, and we're doing that in flight. There's a constant reprioritisation that needs to happen. In terms of the engagement, I think I reported last time that whilst some numbers were low at some of the drop-in events, the conversation was rich, and we're really grateful to those that turned up or kind of committed in writing their comments. So clearly that will come through in the report. In terms of staff, I think I hope Carl won't mind me saying, but we know that the message is out there, and I think a recent visit to one of our sites meant there was a bit of testing. What do you know about Better Together? And all staff seem to know about it, even if there were probably varying levels of kind of detailed understanding. So I would say we need to keep that momentum up. We need to keep engaging and having the conversation, listening to the ideas. But I think from what we've had in the past, I think actually what we've now got is a consistent understanding of the need for the work and the level of input that we need, both from public stakeholders and our staff. I hope that helps.
That helps. Thank you very much. Thank you.
Kate, please come in.
Yeah, thank you. So I've been to, I think, most of the workshops and events, and I'd just like to add that it's been really heartening about the amount of really positive engagement, enthusiasm from all of our staff and primary care colleagues. There's a really really constructive conversation growing, and a real sense of energy around the options and the plan that we had before. It is a massive piece of work, but I think everybody can see how important it is. And I've been energised. I think many of us have, by the constructive nature and then the energy around the conversation. So again, I'd just like to thank all the staff for that, and long may that continue.
Simon, please.
Thank you, Carl, and thank you, Deb, for the paper. My question is one around the next stage consultation and timeline, and awareness that we've got other health boards who are slightly ahead of us in terms of some of their formal consultation around service changes, and whether there's any learning we need to take from their experience in terms of the volume of responses and the time they're taking to ensure they've applied due diligence to those responses, and how we may pull that into our assessment of the timelines we've currently got as we move into that next stage.
Of course, we are constantly watching, listening and learning from others. Just kind of, just a couple of other points. A number of us have been directly involved in engagement and consultation around service change options in other health boards, so we come with some experience. We've got external experts, including clinical expertise, who've also been involved in advising, designing such changes. So they're advising us as we're kind of proceeding. And of course, there was an earlier conversation, wasn't there, about the changes in Hywel Dda, and we know that they've had an incredible amount of response from the public. So we'll watch and wait to see what that means for them and what that might mean that we need to reconsider locally. So all good, but we are very much networked in to the changes that are happening around us and learning from their plan, their approach, and anything that they might have needed to do around their timescales.
Thank you.
Mick.
Thanks, Chair. I only had the privilege of going to one community event, and as everybody said, it was really rich. People were really engaged, but I was struck by the kind of polarized views that were around the room. People with entirely different expectations of what they needed, of what this process might produce. People at the one hand who were options 1, and people who were very firmly option 6. I just wonder what thought we've given to how we get to a consensus opinion at the end of the day that, if people don't agree, they can maybe sign up to, because they can see the, potentially the merit in it, and how we're going to manage expectations. Just my concern is we're kind of, taking people on this journey, and an awful lot of people are not going to get what they wanted from the process. So just some reassurance that we kind of thought that through and we know where we're going with that.
Yes, thanks, Mick. So you're right. We had scenarios 1 to 6, do nothing, through to a DGH. We know that there are members of the public that would be kind of all across that range. We also took the opportunity, and we did it again at the deliberative event, to talk about some of those emerging options and what the hurdle and assessment criteria would be. So we've tested that. And I would say there are probably varying degrees of understanding or support for that, but it is a typical process when one needs to kind of evaluate kind of all of those options, whether they were original options or options that have been submitted by the public. The options appraisal workshop, which had key clinicians, key support teams, also tested that out on a non-financial basis. And of course, we now found ourselves needing to work through the financial bit and the estates bit. And that, going back to the hurdle criteria, that will mean that some of the options might need to be taken back off the table. And I think just talking about how critical it is for engagement with our public, this part of that is explaining how we got from the last conversation we had to anything that we will be presenting. And we need to make sure, I heard the point about digital, I've referred to that, making sure that we are creating the space to have those conversations so that people understand why it is that perhaps their preferred option is not an option that will necessarily be put forward to consultation. We owe it to close that loop and provide the explanation.
Thank you. Are you content, Mick? Yeah.
Yes, thanks. We've clearly contemplated the option that everybody is going to be satisfied. So that's what I was looking for reassurance, really.
So we'll bring in Kate and then Elaine, and then we'll go to the recommendation. Thank you both.
Yeah, thank you. And just sort of further to sort of the engagement and the feedback, I think make the feedback to our staff is really, really important. What we've been careful to do is seek evaluation and reflections on the days and the process. So after the last event, we actively sought reflection from the people participating. We had really, really good uptake on that and feedback, and that is helping us to look at our methods, to kind of reflect on our processes, and either refine or provide the right feedback. I think that needs to continue, because that is a really, really valuable way of seeing whether we are achieving what we wish to achieve, and we will continue with that. So just wanted to add that.
Elaine.
Thank you. I just wanted to provide a small amount of further assurance. So I'm executive lead for the community model piece, the urgent care piece, and the mental health piece. So it's a busy time period, and being in the middle of it, we're in the middle of that process of evaluation and assessment. What I wanted to assure is there's a phenomenal amount of information and logic that's been applied to this. That work is still ongoing, but I think Mick's point in particular, how we then translate that and feed that back to our workforce as well as to our public, is really important. Being close to the detail, I'm not concerned that we haven't got that information. I think we just need to make sure that when we move to a place of consultation, that we take that in an accessible way to our public, and then when we make the decision, that we're presenting that clarity. And I think we've got an abundance of information around that at the moment, and I've been really heartened actually by the level of consideration and the level of detailed explanation that we are seeking, that allows us to then present the balanced information that we're going to need as a board to make a final decision.
And last word to Hayley.
Yeah, thank you. So as we proceed with this process, we're learning as we go along, and capturing that and needing to consider, going back to Simon's point, learning from other health boards and what their experience has been, but also in terms of continuously reviewing our approach locally. I think Mick's point is a really important one, because I think that what unites us in Powys, and what's clear from the discussion so far, is that people are all committed to doing the best that we can to deliver the best possible services for the people of Powys and high quality care. We also know that there's quite a lot of feedback which understands that the current drivers of our issues, including workforce challenges, estate challenges, all of those sorts of things, people can see we need to do something, and we need to do something different. But the devil is in the detail around how best to address and bring those solutions to the fore. And I think one of the issues for us is how, from the start, early engagement in this first stage is about helping us shape the way forward. And we'll continue to be open and honest with the public and our communities and our staff as these options emerge. But I think we can, this does cause, people are open, there's energy, but also uncertainty does create some anxieties, both within our communities and with our staff. So it is something we're going to have to attend to quite a bit as we go through this process, because there will be a situation, for example, when we set out in our discussions around why we feel as a board having a district general hospital in the county is not an option. That is still a very, very strong feature of some of the feedback that we're hearing. So there's a lot more for us to do to have that ongoing dialogue with our staff and the public about what is possible and what isn't really possible in the context of services in Powys currently. So just some reassurance to the board that that constant review, and there will be a tension between moving at pace and moving at the pace by which we can actually take people along the journey with us. And that's one of the issues we'll be reflecting on from the first stage of engagement as we go through to the next stage.
Thank you, Hayley, and thank you, Deb, and everyone. So the recommendation is that we receive and take assurance from the Better Together programme update. Once again, please indicate if you don't support the recommendation. And just before we move on to the next item, I just want to add my comment to the comment that Deb made earlier. I've perhaps had a little privileged glimpse into the enormous amount of work that this is. We always knew that it would be, and we always knew that the capacity needed to take this forward would be challenging. And I think all that I would want to say is that I think what I've glimpsed is not just dedication and commitment, but sacrificial dedication and commitment on the part of our staff colleagues. And as chair of the board and as a board, I simply wanted to acknowledge that and express appreciation and also an assurance of support. So that takes us to item 4.2 on our agenda and the financial performance report, and we go to our Director of Finance, Pete.
Thank you, Carl. Good afternoon, everyone. You will see the finance report included in the papers in the usual format. And as per normal approach, I will take you through the report and highlight the key issues within it. So this is the financial report for the Health Board as of month 5. Our financial position continues to be an area of concern. As a reminder, we are monitoring ourselves against our current plan stroke forecast of 28.3 million deficit position, noting at this point the plan has still not been supported. So as of month 5, we have an overall overspend of 15.7 million. That compares to a planned position against our 28.3 million deficit of 11.8 million, giving us an adverse position against our deficit plan of 3.9 million. The key pressure areas within our plan, the cost drivers remain consistent. Number 1 being in relation to our commissioned activity. There has been an increase in month because we're recognising an increased price that's been applied in NHS England in relation to unplanned care. That increase and that cost had previously assumed to be funded. However, we've received confirmation that is not the position, and we work through and continue to validate the validity of that increase in price and the related impact on our position. But being prudent, that is currently included in our position on a year-to-date basis. Our agency expenditure is still an area of concern, but it has improved over recent months, and I'll pick up more on that as we move forward, as is CHC, and also our continuing healthcare and complex care. Our mental health provider spend is also continues to be overspent, and again, I will pick up on this as I move through the report. Page 2 of the report gives you a summary of our key spend and variance against our key spend areas. And from the table provided, you will see that healthcare services provided from other bodies, our commissioned services, and our other private and voluntary sector, and our continuing healthcare are the 3 areas of overspend. It is worth noting within our position, there are some significant underspends. These are helping to deliver our financial position, but at the moment, those pressures, as I've referred to, are in excess of that benefit. If I move to page 3, this gives an analysis of our health board provider services. The table there details the position, again comparing against our current forecast deficit plan of 28.3 million. And as you will see, that there's a number of underspending areas, and our key area of pressure is in relation to mental health and learning disabilities. And in mental health and learning disabilities, our key areas of concern continue to be the level of agency spend, the level of locum spend, pressure against our complex care and CHC, and in relation to the use of private providers for providing that more complex care for those Powys residents that need it. Page 4 details our expenditure trend in relation to agency and locum spend. As I said, as you can see by the bar charts, they are reducing month on month, which is encouraging and pleasing to see. There is still further action that we can take to improve that position further, but it is also worth noting that currently we're forecasting that we will meet the Welsh Government target to reduce agency spend by 30% in this year compared to last year. Our commission and contracting position is included, and I've referenced the English tariff increase above those inflation levels. Also worth noting that we have got a pressure against our joint commissioning committee position. In our plan, that was assumed to be break even based on the funding uplift provided. That was currently showing a level of overspend, and there is a risk that our overspend could increase. As I've referenced, our private providers position in relation to mental health and learning disability patients, this has been an area of increasing pressure, increasing spend based on the number of individuals requiring care and the cost of that care. This is an area of focus with further alternative actions being identified to try and mitigate and reduce this spend. And there's an assumption within our plan that will be improved. Our prescribing position is also included. This is an area of financial success in terms of being able to mitigate increased cost prices. And in this area, we are on track to deliver circa £1.5 million worth of savings. Also included is our latest continuing healthcare position. Against our forecast and our plan for this year, there is a excuse me, there is a slight overspend as at month 5 of 323,000, and this is an ongoing area of focus. As I move forward to our savings programme, so within our deficit plan of 28.3 million, there is a target of just over 23 million pounds worth of savings. On an encouraging position to note that we currently have 16.6 million pounds worth of green schemes. Those are schemes where there's a high confidence that figure will be delivered within the year. That is significant for the health board and a higher figure than we've delivered in previous years for a number of years actually. What this does mean is that we still have a gap in terms of that target of 6.4 million. That gap is profiled in on a equal basis. So every month we bring in a 12th of our savings target and a 12th of the identified delivery. So 5/12 of the 6.4 million is included in the position, and that relates to 2.9 million pounds worth of pressure against our own deficit plan as part of that 3.9 million I reported right at the beginning. So an area of constant focus for us to close and deliver that gap. As I mentioned, there is an element of operational underspend, which helps to offset some of that gap, but currently that has been totally consumed and exceeded by the emerging risks, which are now included in our position. Worth noting that within the plan is that target of a £2 million improvement against our mental health and LD private provider position. Also included is our current number of risks and opportunities against our plan. And I think it's worth just highlighting that on the back of the position, the mental health directorate has been escalated as a further area of focus, whereby myself and Elaine as exec director meet regularly with that team, looking at the actions being put in place with an expectation that the run rate and forecast position at the end of the year will improve, and that includes the actions around variable pay, private providers and continuing healthcare. So the summary is that we're currently reporting an overspend of 15.7 million as at month 5. This is off profile against our own deficit plan of 28.3 million by 3.9 million based on the areas I've described. Noting the 23.08 million savings target and the 16.6 million position in terms of green schemes, this is an encouraging and good position, but that 6.5 million, circa 6.5 million gap does need to be closed and further actions taken to improve that to deliver our financial plan. Worth also noting that currently our assessed underlying deficit is 42 million based on the non-recurrent actions and fully effective actions and pressures within our position. And then finally, just to note that in terms of our capital allocation of just over 6 million, plans fully in place to spend and utilise that capital as targeted. So nothing to escalate against our capital position. So I think the message is that our continued focus on those areas of cost pressure, our cost drivers are well known by the board, by the organisation, and I think by the population. These are areas that we continue to focus on to deliver best efficiency and best value while maintaining the best care for our population. And I think it's important that all members of the board, all budget holders, are tasked with reducing their run rates wherever possible and reducing spend wherever there are opportunities. Thank you, Carl. I will pause then. I have taken a bit more time to go through in a little bit more detail, but happy to open up and take any questions and comments and discuss further. Thank you.
Thank you, Pete. So we will go to Robert and then to Steve.
Thanks, Pete. Very clear presentation and summary of the position. So 2 questions from me. One, you mentioned that it had been assumed that government funding would be provided to cover the extra costs of NHSE. This turned out not to be the case. Is this likely to be the case next year? And then my second question is about the JCC. Perhaps Hayley be able to comment as to whether we can be confident that they will be able to control some of that overspend. But if there is an overspend, are health boards obliged to make up that deficit? Thank you.
Carl, do you want me to respond?
Please do, Pete. Then we'll go to Steve.
Yeah. So in terms of the NHSE position, so every year there is something that's called the cost uplift factor, which is applied in NHS England in relation to their tariffs and the tariffs that we pay under payment by results. For this year, there's been an additional decision made in NHS England to recognise increased costs in relation to unplanned care. And in relation to that, then there's been a circa 13% increase in tariffs in that area, and that is the additional cost. So it's not an annual event. So can't comment on the likelihood of any further increases next year at this stage. Was that?
Yeah, Robert, are you content?
Yes, so just thank you. That's just the JCC question now.
Yeah, I'm happy to come in on that, Robert. So in terms of the discussion, there has been an additional joint commissioning committee after the papers for this board has been released, and obviously the quite concerning financial position faced by the GCC was discussed. Every health board obviously is part of that committee, and we were very clear that we needed to take additional actions and options around how we can recover that position, because the adverse impact of not meeting the JCC plan, we are obliged as each health board to cover that. What is quite interesting is, due to the risk sharing agreement that we have in place, one of the key drivers currently of being off plan is relating to NHS England growth, and due to the risk sharing agreement, that proportionally impacts us in Powys and Betty Cadwallader University Health Board more than any other health board in Wales. So the JCC team are currently scoping up options around what additional actions can be taken to mitigate the position, as we are at an organisational level, in terms of making up the gap against our current position. And some of the examples of the discussions that we had was around decision making around planned investments, as well as discussions around review of referral management arrangements to be able to mitigate the level of growth that we're currently experiencing. So to give assurance that we've currently got options that are agreed that being implemented. I can't give that at this stage, but I can tell you that the team are currently working up options for the JCC to consider, with a specific ask from health boards to make sure that they take additional options forward to us for consideration to meet the plan.
Thank you.
And Steve.
Thank you, Pete. Helpful report as always. Obviously, a significant concern about the increasing level of operational deficit. I think it's doubled in this 1 month, but I appreciate that's due to the inclusion of the risks around the English tariffs. And Robert did ask the question I was going to ask on that one. You also helpfully outlined the approach you're now taking with Elaine in terms of mental health and learning disabilities overspend. But I wonder if either yourself or Elaine could just provide some further assurance around the controls that are in place before placements are made in high cost external providers, because clearly that's one area that's driving a lot of overspend. And then overall, given that we are now at significant risk of breaching the plan of 28.3 million that we'd signed up to, and I think we'd given assurances to Welsh Government that we would deliver, what actions or further actions are we now being developed to ensure that we remain on track to deliver our plan? Thank you.
Pete, I can see that Elaine would like to come in. Should we? Yeah. So you please respond to Steve's point, Elaine. And then Pete, do come in after Elaine.
Sure, thank you, Steve. So in response to the question around the mental health private providers, it's often quite difficult to put additional governance in place around that, because these are placements that are commissioned at the point of crisis. So these are usually for individuals who are particularly unwell, who are usually sectioned under the Mental Health Act and need a very quick response. We have implemented a number of new initiatives. So we have a weekly control panel in the same way we do with continuing healthcare panels to review every single case and plan and repatriate as swiftly as is appropriate for the individuals. And we've also looked at creating additional assessment space within our own services in order to be able to fully understand what the requirements are of those patients. And we're continuing to monitor that.
So I can see that Mick wants to add to Steve's point and question, and then we'll come to you, Pete. Mick.
Yeah, thanks, Scott. I wanted to ask the same question that Steve asked. We're kind of halfway through the year now. We have a 4 million gap in our current spending run, and 6.5 still to be resolved in terms of the savings. So my question was, well, what can we do about that? But perhaps more importantly is when. So I just kind of go back in time to last year. We got to this point, and we asked the same questions. We were in exactly the same position, and if we're honest with ourselves, we did leave it a bit too late before we responded. So just that question of when is the right time to recognise that this gap is possibly not recoverable in the current plan that we have, and we have to do something differently.
Thank you.
Okay, shall I come in now, Carl?
Please do, yeah.
Yeah, so thank you. So yeah, thank you. So I think there's a couple of approaches to this. Number one, we're trying to make sure that we're fully clear around the elements of our plan that we are delivering against, and those elements within our position which are unplanned, unforeseen pressures which were outside of our original plan, so to make sure that we deliver step one against that original plan. And as I referenced, some of the shortfall in savings would have been offset with some of those operational underspends that would have given us that ability to meet the 28.3 million figure within our plan and forecast. But that said, there are these emerging pressures. As I said, we'll recognise those because it's right to do so within the position. We will work to continue the work to validate the NHSE additional price increases, as I referenced. I think the other actions, just reminding ourselves that we set all areas an additional 2% savings target. Some of those savings identified within that 2% do help to underpin our current position, but there is still potential for some further savings to help improve that further. Not yet a figure that can be quantified or included. I will go back to that private providers position. That is a 2 million shortfall against that savings target. It is a significant amount of the variance within our plan, and as Elaine's just referenced, work in that area to understand, can we reduce that or not? And I think that's key to what it means for our overall position. The other thing to reference is the ongoing work as we've talked about with Grant Thornton and their partners into providing us that bit of a support and approach, and any identified opportunities will be brought into our plan as soon as identified, and we discussed that earlier about that. You know, there's no delay. If they identify something today, we want to know about it by the end of the day so we can start implementing it tomorrow. And that's the sort of conversation we're having. So that's probably the current point, and it links to that, like restricting all spend wherever possible. Clearly then it is it's a board decision then around options and any further options identified, and decision around actions in that area, and around the calling of our position in terms of any change in that area. So that's my comments, Carla. Others may want to add to that.
Thank you. Steve and or Mick, would you like to respond to Pete's response, as it were?
No, that's helpful, and it's good, you know, as you both said, and Hayley said, that, you know, we'll look to respond quickly to anything that Grant Thornton picks up. And I think it's important that there is the ability within the organisation to respond at pace to any opportunities that come forward in that sense. So good to hear that. I suppose the other question, and it's not a question for response now, but is to what extent can our capital programme also help to accelerate any efficiency opportunities? So need to keep that in line as well, but thank you.
Mick, any further comment from you?
No, I mean, I hear loud and clear, you know, the things that we're doing to try and get the position back. It's just, you know, the reality is that, you know, there is a risk that we may not achieve that. And, you know, we just need to be conscious of that. And we also need to be conscious of the timing, because it takes an awful long time to turn the ship around, doesn't it? And we're in September, you know, the next meeting of the board is in November. You know, we're getting towards a point where, you know, anything that we do want to do in terms of corrective action, it gets more difficult as we go down the line. So it's just that plea that, you know, when we know that the time is here to do something different, we need to move swiftly.
Thank you. And I can see that Hayley wants to come in. Please do, Hayley.
Yeah, just two points. So we will need to confirm, based on a month 6 position, our position and how, to what extent we can address the current gap at that point. And I think the timing of those additional actions is important for us as a board, that we will need to take urgent action in that context if we find ourselves that there's still a gap to be identified. But part of the additional external support from Grant Thornton will hopefully help us in that process as well, but recognising that the timeline we're currently working to is to confirm to Welsh Government back on our monthly return, which is month 6. So it'll be at that point we will need to take potentially additional actions as a board.
Thank you, Hayley. Do you have any other comment, Pete? Any additional comment before we go to the recommendation?
Just to say, on Steve's point about any capital opportunities, that is fully considered, and there are areas under consideration around where we could use some capital to help improve our position, to give some other opportunities. So as and when they develop, they'll be reported back.
Thank you. So, colleagues, where the recommendation is that we receive the report, we take assurance that our organisation has effective financial monitoring and reporting mechanisms in place, and that we consider and discuss the financial forecast for 25-26 of 28.3 million, and our underlying deficit of 42.1 million. Does anybody want to indicate that they don't support the recommendation? That therefore is supported, which takes us to our integrated quality and performance report. Before we come to that, just a reminder, because I think Chris is going to introduce this. So just a reminder that we did have the item on the action log relating to this, which was around quality measures. So Chris, if I could ask you to pick that up, please, in the report. And Katie, in your contribution earlier, you did make a comment about this report, and I went to write it down and I didn't capture it adequately. So can I ask you please to just to repeat briefly your point so that we can make sure that it is dealt with?
Thank you, Carl. I think it was the point that related to the correlation, whether there's an observation about any correlation between breaches and the reduction of agency staff.
Okay, thank you. So over to you, Chris.
Thank you, Chair. Firstly, can I just say thank you to my colleagues in the performance team for preparing the report that you have in your packs. And I'll take the board through the report, which is providing an update by exception for those measures that were either unable to meet the national target or have been internally escalated. And colleagues may want to comment on any specifics in terms of performance within the report. So if I can just highlight, first of all, some key messages for the Health Board as a provider. So from a planned care perspective, on measure 26 on page 22 and 23 of the report, you will see from a diagnostic perspective, we've had an increase in breaches from 139 in June to 144 in July. The majority of those are related to echocardiograms, and as a mitigating action, additional capacity is being sought for cardiac physiologists to undertake echocardiograms. From an RTT perspective, the Health Board is fully compliant with the 52-week new outpatient and 104-week treatment targets. Just to highlight, though, that we do have ongoing challenges with the fragility of our InReach services, and this is relating to an earlier discussion around the strategic commissioning framework, an area that we would be looking to address through the implementation plan related to the framework. Measure 28 on page 25 in regards to therapies, we have had an increase in breaches from 20 in June to 37 in July. This is linked to staffing vacancies, and there are mitigating actions in place in terms of recruitment and use of short-term agency. OT hand therapy is a particular challenge that's highlighted in terms of this particular area, but as indicated in the report, there are some mitigating actions there that are identified and being undertaken. Next is audiology, which is measure 29, which is on page 26, and measure 30, which is on page 27. A very small number of breaches over the 6 and 14-week targets due to capacity challenges, but again, mitigating actions identified and detailed there within the report. The next measure I'd like to bring to your attention is for index colonoscopy. That's measure 8 on page 20. Performance remains in escalation. We have a single-handed consultant and there are capacity constraints there. The report does detail mitigating actions that have been identified. And I'd also want just to highlight that Public Health Wales, in terms of the review, are indicating that our service is delivered to a very high standard. So whilst there are capacity constraints, very positive feedback in terms of that review from Public Health Wales. If I can move on to mental health, and particularly care and treatment plans for over 18s, that's measure 44, which is on page 33. You can see that the performance against that particular measure has deteriorated, and we're highlighting there issues in terms of the capacity within the CMHTs not having been fully optimised, but again, mitigating actions identified with the single point of access triage and assessment. And we are expecting performance to reach 90%, the 90% target by the end of October. If I can next bring your attention to children and young people's neurodevelopmental services, that's measure 34, which is on page 29. As Kirsty mentioned earlier, very positive that there's been internal de-escalation within the Health Board, and that performance against the 26-week target has improved. I do want to highlight, though, if I may, you will see that there's been an increase in the position in terms of breaches over 104 weeks. This has been as a result of, and we've had a large cohort of patients who've moved into the Powys area. They have long waits. The service does have a plan to address. And just to pick up on an earlier conversation as well that we had around the sustainability of the service, we are now expecting a report from the service against the sustainability conditions that have been set. This will include a focus on how the service will maintain improved performance and also pick up on the quality of service and patient experience. And then lastly, the progress in terms of meeting the Welsh Government standards for the delivery of children and young people's neurodevelopmental services. If I can then move us on to the Health Board as a Commissioner, and firstly, if I can bring your attention to planned care from an NHS Wales perspective, that's measure 31 and 33, which is on page 46 and 48. You can see that there are, as of July, 365 patients waiting over 52 weeks for new outpatients. Swansea Bay and Hywel Dda are performing very well. Swansea Bay have 0, Hywel Dda have 1. And in terms of those waiting over 104 weeks, Swansea Bay have achieved 0, and we do have very low numbers waiting in Aneurin Bevan, Cwmtawd Morgannwg, and in Hywel Dda. From an NHS England perspective, that's on pages 47 and 48. You can see there that Wye Valley currently have 117 patients over 52 weeks, but have maintained 0 over 104 weeks. Shrewsbury and Telford have 331 patients over 52 weeks, but again have maintained 0 over 104. There's a very large cohort of patients over 52 weeks in Robert Jones and Agnes Hunt. That's at 824. And we have 56 patients over 104 weeks. That's split between 18 for spinal and 38 for trauma and orthopedic. And that would be on a subspecialty level across arthroplasty, knee, sports injuries, and foot and ankle. If I can next bring your attention to cancer performance from an NHS Wales and NHS England perspective, that's measure 25, and you'll find detail on pages 44 and 45 in the report. Performance against the 62-day target is remaining challenged in both England and Wales Commission services. Wye Valley Trust is the only commission provider that's showing a consistent positive improvement towards the target and does report a better than all England average for all measures. From an NHS Wales perspective, you can see the detail there in the report that it continues to be very challenging, although we have seen an in-month improvement from 57% compliance against target in June to 66% in July. From an NHS England perspective, as I mentioned, there's been that improved performance in month for Wye Valley. If I can just bring to colleagues' attention the reporting issue that we've identified in terms of the performance we presented for Shrewsbury and Telford, that we've only been reporting breaches over 104 days, and that's been due to a change in data source. This will be rectified now, and we will provide a more complete position report from month 5. If I can then bring colleagues' attention to urgent and emergency care, and that's measures 19 to 24 on pages 39 to 43. Some issues that I'd just like to bring to your attention, if I may. Firstly, in regards to the new measures from a Wales Ambulance Service perspective and the 8-minute response time. There's new reporting from August on the new categories, which is purple for arrest and red for emergency. You'll see there is a particular challenge there in terms of Powys performance for the red category, and we are exploring that with colleagues in WAST to understand the issues and the mitigating actions that can be taken. And lastly, on urgent and emergency care, just to highlight to colleagues that no commission service is meeting the national 4 or 12-hour targets, but Wales ED departments are performing better than departments in NHS England. Just then, Chair, to bring the report to a close, just to highlight to colleagues on page 37, we are bringing to colleagues' attention the National Quality Outcomes Framework, which NHS Wales Performance and Improvement have led the development of to support the identification, monitoring and learning of quality and safety improvement priorities. We will be looking to include that in board level reporting from October 2025. So just to bring that to colleagues' attention. And then just to highlight as part of the next steps, as well as reporting on the National Quality and Outcomes Framework, NHS Performance and Improvement have also developed a dashboard around the NHS Wales Planning Framework Enabling Actions, which will be has gone live at the end of September. We will be looking to include that going forward in our performance reports. We will provide the updated position on the Shrewsbury and Telford cancer performance. And then to pick up on one of the actions you mentioned, Chair, in terms of outstanding from the last meeting, we're continuing to work to align this report with the integrated quality report, and the latter of which now will include commission service information. The Health Board has established the Commissioning Oversight and Assurance Group that's chaired by Nicola as the Exec Director for Planning, Performance and Commissioning, and that will now inform the quarterly integrated and quality report that will be presented to PECS. Conscious, Chair, that's a very quick canter again through the report, but happy to take any questions.
Thanks, Chris. So just for my own clarity, in terms of the ongoing action on our action log, clarity to be provided on reporting of quality measures in this report. You talk about it as being an ongoing matter. So I'm assuming that we're not going to close that. Is that right?
Claire, did you want to come in first before I comment?
So, Chair, I'm quite happy to come in on this matter as well, because this links to the publication of the National Quality Outcomes Framework, which has been published by colleagues in the NHS Wales Performance and Improvement Services. We have received correspondence around those, which are 20 measures in total, 14 of which are being launched in October. We actually have a meeting this afternoon, myself, Chris, and other colleagues, to be able to look at that and to be able to determine how we implement that within our existing integrated quality and performance framework. So I just wanted to give that update because that is a really important piece of national work that we will need to take consideration of now as we build our quality management system in the IQPF.
Okay, thank you, Claire. My suggestion then is that is an ongoing matter. Those measures from that new national framework do need to be incorporated into this report, and therefore we'll keep it on our action log, and therefore will remain cited on it. So thank you for that. And just before I bring others in, Chris, there was Katie's point about is there a correlation? Correct me, Katie, if I misrepresent you, but is there a correlation between increase in breaches and decrease in agency spend?
Thank you, Chair. I don't know whether Claire or Lane might want to comment from a service-specific perspective.
I'm happy to comment on that one. Thank you, Chris and Carl. So the short answer to that is no, I don't see a correlation. The vast majority of the agency changes have been supplemented by additional substantive recruitment and bank recruitment that we've put in place, and that relates primarily, there is some that relates to psychiatry, medics, and there is some that relates specifically to ward, particularly in our community service group. So it doesn't specifically relate to the breaches that we can see in this report.
Thank you. So I'm going to invite a few colleagues now to come in and contribute to the discussion, and then we'll come back to you, Chris. So we go firstly to Robert.
Oh, thanks, Chris. Just a very quick one from me. A plea really to keep us informed on the AMBER responses as well, because they do obviously include some serious conditions. And bearing in mind what we discussed earlier and the time it's going to take then subsequently to reach a DGH, I think that is also a relevant statistic. Thank you.
Ian, please.
Yeah, thanks, Jay. First of all, Chris, can I just say, yeah, thanks for that presentation. And obviously, this is a very, very substantive report. There's a lot of good things here. There is a lot of assurance I feel I can gain from what we've said, and notwithstanding some of the other comments and potential correlations, I actually happen to be in agreement. I don't think there's necessarily a correlation between agency staff and breaches at the moment. I do think there are a couple of things that perhaps I'd like a little bit more assurance on. And I don't want to go through these individually, obviously, because there's just too many. But as I said, most of this is perfectly fine. If I could just pick up on your audiology, perhaps for my and the public's understanding as well. The people of Powys here on this one. In relation to pediatric audiology, the report states that we're reliant on a single clinician service for the whole of Powys. I'm just wondering really whether that would be normal given the size of the population, and whether we have other trends of this nature specific to Powys because of the rurality of the county. And I'm just curious as well, again, this is a bit of a point of detail really, how a single audiologist can actually cover a paediatric audiologist can actually cover something the size of Powys. So perhaps a little bit more assurance in that area, please.
Thank you, Ian. I know that Claire would like to come in on this, but we will come back to that.
Okay.
Let me bring Simon in.
Thank you, Chair. I wanted to pick up on the care and treatment plan, noting performance has declined, and that this is inextricably linked to capacity in the county council and the part they play in the process. So I just wanted to get some assurance as to whether we have a line of sight and understanding as to what, if any, actions the county council are taking with regard to their capacity concerns, noting that there's some positive news around appointments in our own capacity, which should be helping. So really just want some assurance that the county council is taking actions to address some of those capacity issues. Thank you.
And Mick.
Thanks, Carl. My question was around the quality outcomes framework. Really positive development. That it's important we see that balance between the kind of timeliness and metrics and the quality and safety of service that's being provided. But just wondered whether we will be kind of accountable for, or be able to monitor and assess just those services that we provide ourselves, or will we also get data about our commission services, and to what extent are we able to influence that, and to what extent are we held to account for that? So that was the first point. The second was just a minor issue. I think it probably 18 months that I've been with the board, we've been reporting the 3 healthcare acquired infections as not rated because of ongoing discussions. I just wonder what it is that's taking that long, why we're not able to resolve that. And just some reassurance that it doesn't mask some sort of hidden problem that we're not aware of.
Thank you, Mick. And at the risk of over egging the pudding, Chris, could I just ask as well, please, how do we make sense? So in the performance report, for example, we read that our compliance in terms of mental health under 18s assessment and adult assessment has been achieved. But yet in the Llais report that Katie presented earlier, where we have the Llais patient voice telling us that people are still saying that access is really difficult, both to assessments and to the service. So how do we make sense of that seemingly conflicting source of information?
Thank you, Chair. If we wanted to address that one first, Elaine, I don't know whether there's any comment you wanted to particularly make on that before I give my views. Oh, thank you, Elaine.
Yeah, absolutely. So 2 questions for me. One is yours just there, Carl, around the alignment between our reported mental health measure and also the CLICE report. And I'll also pick up the comment around care and treatment plans and our link with the local authority. So in terms of our mental health measure, that's quite a clearly defined measure that we have to report against. So we've also introduced 111 Press 2, and we've aligned that through to our services. So people don't necessarily have to wait and go to a GP for a referral. They can call 111 Press 2 and they can get through. And then we will assess them and we will count their achievement against that initial assessment and treatment target based on the moment that they get in contact with us. I think that service is still relatively new, so it's been in place for just over a year, and I think some people will still struggle with understanding that it is there and that's how they can access service, or whether they need to access service through another route through their GPs. So the perception of access and the reality of access and how people may contact us might be different. So I think that there continues to be more work that we have to do to share that information around how you can access on the day into our services and how we will respond accordingly. So I think we're in that transitional period between what people believe and what people's experiences are and the route that they may have tried to take to access us. So we can look at that. I think the other point that you made, Simon, around the local authority and the care and treatment plans, I think that is challenging. I think we have some really good relationships with the local authority. We have regular meetings to connect on a local basis between our community mental health teams and the care and treatment plans that we hold. And those care and treatment plans and the review of those are held by different professionals. So that could be a psychiatrist, it could be a nurse, it could be a social worker. We have to report against that. The local authority do not have to report against that. So that very much relates to the working practices that we have, which are generally really good, and those will stay in place and remain. Some of the poor performance that we've got doesn't relate to the local authority, it relates to our own systems and that transitional period we are in, bringing in our single point of access and diverting some of the activity of our staff into that implementation. So as as Chris reported, we would hope that by the end of October, and if not by the end of October, certainly mid-November, we would be looking at a significantly improved performance there.
Thank you. So perhaps I can bring in now Claire Roche to cover the HCAIs and the monitoring of quality across provider and commissioner services. And then Claire Madsen might want to make a comment on the question about paediatric audiology. Thank you, Claire Roche.
Yeah, thank you, Mick, for the question. So you'll notice in the report that it says about PTHB not being an acute service provider. We do report through the integrated quality report, and we do report through to Welsh Government on a monthly basis through IQPD, our community C. difficile cases and any other cases of healthcare acquired infections. Those figures are extremely low in terms of a data perspective, and we're not actually required to report that through to the HARP team. We have been doing some work with our commission services in terms of understanding it from a population perspective, but unfortunately, infection control and healthcare acquired infections are reported on a provider perspective in terms of the provider from the District General Hospital perspective. So we are trying to work with Public Health Wales on really understanding a population health basis from a Powys perspective, but it is not consistent with the way in which the data is reported. I know that's a bit of a complicated answer, and I'm really happy to pick that up outside the board as well.
Thank you, Claire. And Claire Madsen.
Thank you, Chair, and thank you, Ian, for the question. Yeah, it's a complicated situation with audiology. It's worth remembering our situation in Powys. We don't have a DGH or any medical staff, so we only provide community services for paediatric audiology cases. So our numbers are actually very small and quite fragile. So we also commission all of our acute services from our acute providers. We are looking to repatriate, and we actually commission some of our community services in the north, and we are looking to repatriate that because that would give us a more critical mass of patients, so we could have more staff. It is one post, but it is 2 people, so that enables us to cover our geography a little bit better and cover annual leave and that kind of thing. And we do have a really excellent relationship with Swansea Bay, who provide all of our clinical supervision and governance for these patients. So it's very easy to breach with these patients because one person being off tips us over the edge really quickly, but we are looking at how we can expand that service in the future.
Thank you. Thank you.
Thank you. And I know that, Chris, we will come to you, particularly around the WAST and AMBER things. Mick, you'd like to come back in?
Yeah, sorry, Clegg, I understood the issue with the 3 HCAI measures, but just on the broader issue of when the quality outcomes framework is implemented, some of those things are probably mortality rates and antibiotic prescribing, those kind of things. They, unless I'm mistaken, probably more lend themselves to what happens in commission services. So will we be accountable and will we be able to differentiate our performance, our quality performance in terms of local service provision and that we commission externally? And will we be held to account for the outcome measures, quality outcome measures for provider services as a health board, or will we do that through the commissioning framework?
So in terms of the National Quality Outcomes Framework, I think that still needs to be determined and is unclear. And that is a conversation that we will need to have with the NHSI performance and improvement colleagues. My understanding is that this will probably be addressed through our strategic commissioning framework. And Chris, I don't know whether you would agree with me on that matter. But clearly what we are meeting to address this afternoon is how do we ensure that the newly published National Quality Outcomes Framework is embedded within our organisation in relation to the existing frameworks that we have, both the Integrated Quality and Performance Framework and, of course, the Strategic Commissioning Framework. So I would hope, Mick, that in future quality committees and in future boards, we would be able to articulate that in a much more clearly understood way.
Thank you. So finally to you, Chris, and particularly around the AMBER calls.
Yes, thank you, Chair, and thank you, Robert, for the question. And apologies, I should have mentioned that within the context of the ambulance response framework, phase 1, as colleagues are aware, was the introduction of the purple for arrest and red for emergency. There will be some further developments by the end of this year to be introducing new categories that will replace the current AMBER reporting mechanism. So we will be looking to reflect those in reports going forward as well. So just to thank Robert for the question and to provide some assurance that we will reflect that updated framework in future reports. Thank you, Chair.
Thank you. So the recommendation is that we discuss the report. We've certainly done that. Importantly, that we take assurance that the Health Board has appropriate systems in place to monitor performance and to respond to relevant issues. I'll pause so that if anyone wants to dissent from supporting the recommendation, you can do. Now, please do. So that is supported unanimously. I do promise that we will have a lunch break, hopefully imminently, but we do have one item still to consider just before our lunch break, and that's the annual delivery plan performance report. And I think that in Nick's absence, Sam Ruthven-Hill is going to just introduce this to us. Take the report as read, Sam. We don't need to be taken through it, but please do come in with any additional comments.
Thank you. Good afternoon, everyone. I'm Samantha Rivenhill, Assistant Director of Planning at the Health Board. So this report provides an overview of progress against the Health Board's annual plan for the current year for the period of April to June 2025, so the Q1 period. It covers the whole of the annual plan and responds to both the context of the local long-term shared health and care strategy and the wellbeing objectives within that, and also to national requirements set annually, including those ministerial priorities that are set out in the NHS Wales planning framework. There have been updates to planning requirements in year. Notably for Q1, the Ministerial Advisory Group report on performance and productivity in NHS Wales and the associated recommendations. The design of this progress report has therefore been updated so that we can reflect alignment with those. Overall, the report demonstrates good progress against the plan. Given it's 1/4 of the way through the year, a number of deliverables are not yet due. So it's positive to see that 42% of the plan is recorded as on track or completed. 11% is recorded as at risk and 1% is behind schedule. That equates to 5 deliverables. For each of those, a reason for delay is given and action to recover and the relevant timeline for those. Key achievements are also included in the cover paper, following feedback at previous board meetings to strengthen the report if we can, to give more insight into the difference that the actions in the plan are making for the population of Powys. So you'll see that that spans a huge range of work being done in Q1, including breastfeeding, vaccination, screening for cancer, ophthalmology and dermatology, and other achievements in areas which enable healthcare, such as workforce, digital, and our environments and estates. Following consideration here today, this report is also provided to Welsh Government so that they have a formal record of our progress for Q1. Thank you.
Oh, thank you, Sam, and thank you for stepping in, as indeed did Chris, given Nick not being with us today, so appreciated. Colleagues, does anybody want to indicate that they would like to enter into discussion, ask a question, make a comment in response to the annual plan report? Simon, please.
I have a quick question, if I may. Do we, on page 6 of the report, it notes a recommendation for Welsh Government to carry out a rapid study of longest delays to target, to help target investment. Do we know if that's taken place, and do we have any sense of whether we think any investment would be heading in our direction as a consequence?
Please come in, Sam.
Thank you. I wonder if I could go to the executive who may have more knowledge on that one, who provided the comment in the report.
which
I
will
can
be
see that
Elaine.
Elaine wants to come in, please do, Elaine.
Yeah, I think that's me. Unfortunately, I don't think I've got anything clear to give you at this point, Simon. So no, I don't believe I've seen any outputs from that review, and no, I haven't seen any money coming our way as yet.
Okay. When was the MAG report published? Because it does, if the recommendation was for a rapid review, I'm just wondering what that actually means. Thank you.
Okay, Hayley, would you like to help?
Yeah, so there were a number of recommendations in the ministerial report, Simon, a number of recommendations. Some of those had specific timelines, and some of them were for national pieces of work and some of them for local determination. So we do track our local progress against the recommendations within the report, and I actually attend a meeting with Welsh Government colleagues regularly to provide an update on that. In terms of the specifics on that, I think we need to just double check the timeline on that particular recommendation and where we are. But just to give you some assurance, there has been substantial work done both locally and nationally on a range of recommendations within that report. But there was a concern at the rapid the word rapid, because a lot of them are in a matter of weeks that needed to be completed. So perhaps we could bring that to a future meeting, Simon. Thank you.
Great. Many thanks.
Thank you both. And of course, just to remind ourselves, this report has already received detailed consideration in our Finance and Performance Committee, and we had that source of assurance in the F&P report earlier, so much appreciated. In which case, the recommendation is that we consider the report ahead of submission to Welsh Government, as Sam explained earlier, and that we take assurance that there is a process in place for monitoring progress against the plan. Again, I will pause should anyone want to comment on the recommendation or indicate that they don't support it. That therefore is also supported unanimously. Which actually brings us to our lunch break, a little later than scheduled, but not too much. So, colleagues, can I suggest that we take a 20-minute or so lunch break, and that we reconvene, therefore, let's reconvene at 13:35, 25 to 2. But thank you so much for your attention so far, and have a good lunch. Buon appetito.